we added that you shouldn't be getting what do you call it? I mean negative or below negative 20 as well, because if the suction is below negative 20, okay, centimeters of water, that one we are not going to get a correct what negative pressure to maintain a suction in the what in the drainage system. Okay, so that was that. We established that in the suction control chamber. Then we went to the water seal. We established also with that with the water seal chamber, there is water. It should be at 2 centimeters. Okay, we are going to expect what a rise and fall when a patient breathes in and out. We call it tidalling, right? It is a normal finding. The tidalling is a normal finding, and we are going to expect it anytime the patient breathes in and out. Now, we also made it clear that, or we studied the other time, that when the lung begins to re-expand, when the lungs begins to re-expand, that intensity in the tidalling begins to reduce. Okay, that intensity in the tidal, the rise and fall, will begin to go down as the lung begins to re-expand. Okay, the moment we see continuous bubbling in the air leak, the air leak monitor, we are seeing what? That there's an air leak. It should be intermittent bubbling. When we talk about the air leak gauge or the air leak monitor, we are expecting an intermittent bubbling over there. Once we see a continuous bubbling, it means that there's an air leak. Okay. The last thing we spoke about the collection chamber. We spoke about the collection chamber. The collection chamber is where the fluid will drain into from the patient's chest cavity. Okay, where the fluid drain into the patient's chest cavity. So there is something little you should just know for your NCLEX. Okay, just something you should know for your NCLEX. Something simple. Then we also went ahead and explained some few things concerning the chest tubes, right? Yeah. So when the chest tube dislodges from the chest drainage system, are you getting the point? Not from the patient chest cavity, but from the drainage system. The moment it dislodges, you have to look out for two things: did the tube get contaminated or not? Okay, so if the tube gets contaminated, like it hits the ground, at that point we can't fix it back into the drainage system. So you place it directly into what? A bottled water, at least 250 mils to 300 mils. Okay, between 250, 300, 400 mils. Within that range, you should get a bottle of water in within that range, and you place the tube into it. It serves as the drainage system. Okay, but the moment it doesn't get contaminated, like the tube dislodges accidentally, but it doesn't get contaminated, you can just wipe quickly. Okay, just clean it using an antiseptic lotion or something. Just clean it and then fix it back. Okay, good. And then just fix it back. So that is something you should take note of, right? Good. So you place it inside the bottled water when the tube gets contaminated. Okay, very good. So that is something you should know when it comes to the dislodgement. Now, when it dislodges from the patient's chest cavity, ideally, what you should do is that you should try and cover the area with a gloved hand to prevent what air from entering. So in fact, you instruct the patient. Okay, you instruct the patient the moment the tube dislodges. The moment the tube dislodges from the patient's chest cavity, okay. Yes, is it Idrisu? I don't know whether I'm male or female. Kindly forgive me. You can speak.
Yeah, boss. Please, I want to find out if the tube dislodges and touches the ground. How do you determine whether this one is contaminated or not contaminated? Thank you.
Okay. Okay. So usually, when it comes to chest tube getting contaminated, okay, when the tube dislodges from the drainage system and then it touches the ground, okay, it touches the ground. Usually, when the tube, accidentally, okay, or it gets into contact with any non-sterile material around the area, we consider it contaminated. At that point, we can't reinsert. Okay, you can't reinsert. Okay, but then when it gets contaminated, you can't reinsert into the chest unit system. Otherwise, I'm going to contaminate the whole thing. Okay, so that is when we say the tube has gotten contaminated. Okay, but then when it leaves and then it doesn't touch any, non-sterile material over there, doesn't touch the ground, Then you can just, clearly dip it inside the machine. Okay, all right. Are we fine? Okay. So these are things we established, right? Good. Yes. So when the tube get exposed to unstable environment, then we can see. All right, Madam Patient, you
Hello.
can talk.
So,
Yes, yes.
so please, what if the question didn't state whether it got contaminated or not?
Very good. So if the question did not state contaminated or not, please pick the bottled water. I think I said the other time. Okay. If the question did not state whether contaminated or not contaminated, just pick the bottled water. Okay. Yes. So that is it. Right. But if it gets contaminated by touching the floor, coming to contact with material materials, those things, you can't reinsert. Okay. You can't reinsert. Right. So that one, you should just get the bottled water. You can't reinsert. But when it leaves, and then right away you'll be able to identify without any touching the non-sterile equipment or the ground. You can now just what reinsert and fix it. Okay, very good. Then when it discharges from the patient chest cavity, if the tube dislodges from the patient chest cavity, instruct the patient to exhale forcefully immediately. Okay, they must exhale. The exhalation will prevent air from entering the cavity. When you breathe in, that is when air comes in. And when you breathe out, that is when air goes out. Right? So the moment the tube dislodges from the patient chest cavity, instruct the patient to exhale forcefully. Then you can cover with your gloved hand. But mind you, please mind you, when you cover with your gloved hand, it shouldn't be there for long, because the more the hand stays there, it increases pressure in the thoracic cavity or the pleural cavity. So the moment you place your hand, be preparing for what? Your three-way occlusive dressing, please. So you insert the patient to what? To cough or exhale forcefully, and then you cover with your gloved hand to prevent air. Then quickly attach your dressing, and then tape it what? Three-way, leaving one way for what? For air to escape, and then preventing air from entering. That is something you should know. When it comes to the volume we should be expecting within an hour, it should be 100 mils. Okay, 100 mils per hour. Anything above 100 mils could mean that there is blood, or you are draining too much. It can lead to hypotension, because we are going to decrease the patient's fluid volume. Okay, so it should be 100 mils per hour. Now, please take note. When you see dark colored blood in the tube, especially after a surgery or especially after inserting the tube, please, it's expected, even if it is above 100 mils. Okay, please take note. When you see a dark uh, colored, what do you call it? A dark colored blood, okay, usually it's those ones are expected. So when you see them, you document. It is only bright colored blood, okay, or bright red. Bright red is when you report to the healthcare provider. Are you getting my point? So please take note. When it is dark blood, you can document, especially when it's after a procedure. Okay, you can document. But when it's bright, it could mean severe bleeding. You should report to the healthcare provider. Okay, so these and certain things we established the other time on chest tube. Okay, on chest tubes. I'm sure we are on the same page, right? Good. We are all on the same page. So please, let's take note of this for our English. We can go over them all the time because the recordings are there. All right. So there were some questions we were doing before the computer shuts down. I just want us to go through them quickly before we can continue with what do you call it? The tuberculosis. Okay. All right. So let's start going to the topics, the questions. All right. So the first question was this. So I'm reading, okay. Yes. You are providing care to a patient with pneumothorax who has a chest tube. On assessment of the chest tube, it's the question or something. But I'm Cecilia. Today's your first time joining the class. Yeah, you've not missed you've not missed much, okay. But don't worry. Any class you made, the recordings are there, okay. The recordings are there on your dashboard, right? Yeah. You communicate right after the class, okay, so that you have access. Okay, you will now have access to your dashboard. All the recordings are on the dashboard. You can have access to them and then go through them. Okay, all right. So don't worry at all. Good. So you are providing care to a patient with pneumothorax who has a chest tube. On assessment of the chest tube system, you note that there is no fluctuations in the water tube chamber as the patient inhales and exhales. You check the system for kinks and find none. What is the next action? You are picking C, right? We are all picking C. I can see C here. Right. So this one, the answer was clear the other time. So the answer is C. It is normal for the water tube chamber to tidal up and down as the patient breathes in and out. If there is no fluctuations in the water tube chamber, there may be kinks in the tube or the lung has re-expanded. Therefore, it is important. To check the system for kinks. If there are none, then you check the patient lung sound to see if lung sounds are present on affected side. Hence, the lung has re-expanded. Please, I want you guys to pay attention here. Someone asked a question the other time on this slide and then asked if you had a question on the ankles. This same question, you went and then the patient fluid was not draining or probably there's no tidaling as expected. What should be the first thing to do? Should, in case the question state, let's say option A, auscultate the patient lungs, and then option B, check the tubes or check for kinks or obstructions. Please, let's take note. The right answer, the first thing to do is to auscultate the lungs. In chest tubes, when it comes to chest tubes, and then the fluid has stopped draining, please, the focus is on the patient. Auscultate the lungs first. It is the patient first before the device when it comes to chest tube. So please take note of this. Well, if you see some of these other rationales, whether you are solving some question and you saw different thing, please, you would stick to this idea, okay, or this point I'm making, that the first thing to do is to auscultate the patient lungs. You check and see if the lung has re-expanded. Now, when you auscultate the patient lungs, there must not be any diminished lung sound. There should be a normal lung sound. Once you keep on hearing a diminished lung sound, it means that the lung has not responded or expanded. Now, you can check for kinks and obstructions in the tubes. Okay, so the first thing you do when the tube or the fluid stops draining, please, is to do what? Auscultate the patient lungs and check and see their normal lung sounds. Then, if not, you check for kinks. Now, if you check and see that they are normal lung sounds, then the patient lung has re-expanded. Now it is time for what? Chest tube removal. Okay, it is now time for chest tube removal. Are you getting a point? It's now time for chest tube removal. Okay, the patient will breathe in, hold, and bear down once you take off the tube, and then we are there. After the procedure, remove the tube, we take an X-ray to confirm that there are no air, there are no fluid in the pleural space. Then we are good to go. Okay. All right. Now next question. Let's go to this. Next question. Yes. Can someone read? Who will read? Okay, let me read it so that we can move fast. A patient is receiving mechanical ventilation with PEEP. I'm sure you all know the full meaning of PEEP. It is positive end expiratory pressure. Usually use the mechanical ventilations, okay? Positive end expiratory pressure. Now, when you are using the positive end expiratory pressure, it can cause barotrauma, okay? Barotrauma. Barotrauma is when there's a rupture of the lungs due to increased pressure. This positive end expiratory pressure, if you increase it too much, when the patient is on a mechanical ventilator, it can cause rupture of the lung, and that is what we call barotrauma, and can lead to what? It can lead to pneumothorax, okay? Because once the lung ruptures, air will leak into the pleural space. The pleural space is just the space between the lungs and the chest cavity. Are you getting a point? So the patient had developed a tension pneumothorax due to the PEEP, right? Select all the signs and symptoms that can present with this condition. Tension pneumothorax, yes. Which of these signs is consistent with tension pneumothorax? Yes, let's answer it. Please, are we here? Okay, so I see AGEF. Any other rationale? Any rationale? AEF, ADEF. Okay, Madam Patience, you can speak.
Hello.
Yes.
Yeah. I chose A, D, F because last week you made mention that for the hypertension it occurs because the the aorta and the vessels of the heart are at the back of the lungs, and so as it expands, it puts pressure on those arteries, and so there will be decreased cardiac output, leading to hypertension. And so because there is much pressure on the lungs, there will be tracheal deviation. And so because the lungs can't expand for oxygen and carbon dioxide to be exchanged, there will be decreased oxygen in the blood, leading to hyperemia and tachypnea. That is why. Thank you.
Okay. All right. So, well, Madam Mary, you wanted to speak. Can you come up with a rationale too? You can raise your hand there. If you're okay too, you can move ahead. Right. So there's hypotension, jugular vein distension, bradycardia, tracheal deviation, hyperemia, and tachypnea. Let's look at the answer. Okay. So the answer is A, B, D, and F. So hypotension, jugular vein distension, tracheal deviation, tachypnea can all be present in tension pneumothorax. The other options are not usually present. Okay. So hypotension, because there's compression of vena caves. When the vena caves are being compressed, there will be limited amount of blood being spilled out into the heart for cardiac output. So there's going to be low cardiac output and hypotension. This same way, because of the pressure, can increase, the compression of vena caves will increase pressure in the what? The jugular veins, okay? It can be distended as well, right? Then there's patients having issues with breathing. So the compensatory mechanism will increase their respiratory rate. Are you getting the point? Then there's what? Tracheal deviation. Okay, so we are getting what? A, B, D, and an F, right? Good. So next question. A patient has a chest tube for treatment of pneumothorax in the left lung. Which finding during your assessment requires immediate nursing intervention? A, the water switch chamber has intermittent bubbling. B, the patient has slight tracheal deviation to the right side. C, the water switch chamber fluctuates while the patient inhales and exhales. D, the patient complains of tenderness at the chest tube insertion site. Yes. Okay, Madam Patient.
Sir, please, can I see the questions again? The one that we just finished.
So you've seen it now,
Okay,
right?
okay.
Yes.
Yes, please, let's go to the
All right, so let's answer this one. Oh, some people are picking you. I see Madam Cecilia picking D, or Papa May picking D. Yes, B. I showed the answer already. So a chest tube for tension pneumothorax in the left line, which finding during assessment requires immediate attention, right? The water seal chamber has intermittent bubbling. The water seal chamber has intermittent bubbling. It is expected, right? It is continuous bubbling that is not expected in the water seal chamber and the air leak monitor, right? So that one is perfect. Now let's move on to see. The water seal chamber fluctuates when the patient inhales tidally, expected, right? So no immediate intervention. D, the patient complains of tenderness at the chest. It is normal. If a patient is being on a chest tube, you are going to cut. Before we can insert the chest tube, you are going to cut. Okay. So because we are going to cut, definitely the patient will feel some pain around the area. And when you touch the area, the area will be a bit tender because a blade has touched the patient's skin. So this one is expected. And in prioritizations, you know that unexpected beat expected, right? Something like that. So you should know that, right? Good. So once the patient's area has been cut the bleed and your patient is having tenderness, expected. But once you are getting a slight tracheal deviation to the right side, that one needs immediate attention. Now, mind you, sometimes our mistake during question is that you don't read the questions very, very well. The question stated this. Let's read it again. A patient has a chest tube for treatment of pneumothorax. The question didn't specify tension, open or closed. No. The question just said pneumothorax. There was no mention of whether tension, closed or hot or open. And I made mention earlier on the other time we met that tension pneumothorax is a life-threatening condition, right? So when we are seeing a tracheal deviation to the right side, this will mean that the tension the pneumothorax is now becoming complicated and it's becoming a tension one, which needs immediate intervention. So that makes the B the right answer. Okay. Okay. All right. So the answer is B. A patient with a chest tube is at risk of tension pneumothorax due to risk of pressure building up in the pleural space. Therefore, the nurse would want to monitor the patient for this. And if tracheal deviation is present, this is a major sign of tension pneumothorax. Okay. All other options are normal findings. The water seal chamber has intermittent bubbling because the air, these are all normal. Fluctuates up and down. The patient, it is tired silent. It's also normal. Okay. So please, and it is also normal for patient to have tenderness at the inserting side, okay, of the chest tube. So please, it is normal. Okay, it is normal. Right. Good. Next question. Yes, next question. Can someone read, please? Who can read for us? Madam Patience, can you read? Okay, Madam Abigail, please read.
Okay. Which statement is correct about tension pneumothorax? A. This condition happens when an opening to the intrapleural space creates a two-way valve which causes pressure to build up in the space leading to shifting of the mediastinum. B. Tension pneumothorax is a medical emergency and is treated with needle decompression. C. Tracheal deviation is an early sign of tension pneumothorax. Then D. An open pneumothorax is the only cause of tension pneumothorax.
Okay, what's the right answer? A. This question, can it take time? Okay. This question, can it take time before you get the right answer? I'm seeing B. I'm seeing B. BC, BC, right? BC. I'm seeing BC, BC. All right. B. So the answer, we are tossed between B and C, right? Okay. So those who are picking C, why? I want a rationale. Why? Okay, Madam Mary, yes.
Hello. Thank you very much. I will take the B. Tension pneumothorax is a medical emergency and is treated with needle decompression. Although the tracheal deviation is a sign of pneumothorax, but I don't think it's the early sign. Hello.
Okay. Yeah, I'm here.
That's why I'm taking the B. It's always a
Okay.
medical emergency. So you
Okay.
have to, if you don't do
All right. I want someone who picked C to also give me a rationale for the C. Madam Patient, Madam Celia. Yes. Any rationale, Madam Patient, any rationale, Madam Celia, for the C. Why C? Okay. All right. So the right answer here, actually, eh, which statement is correct about tension pneumothorax? Okay. A, the condition happens when an opening in the pleural space creates a two-way valve. It is wrong. In pneumothorax, the valve is only one way. Okay. It is a one-way valve. That is why air enters and does not escape. I think I explained it at that time. The reason why air enters the pleural space and does not escape is because it's a one-way valve. Okay. It is a one-way valve. Okay. All right. So not a two-way valve. And then A, B, tension pneumothorax and medical emergency is stated within the decompression. Okay. Then C, tracheal deviation and any sign of tension pneumothorax. D, an open pneumothorax is the only cause. No, closed one can also cause it. Closed one can also cause it, okay. And then mind you, even closed tension pneumothorax has a higher chance of causing tension pneumothorax more than open. Because open, at the point in time, air can escape. Okay, because there's a hole on the patient chest cavity. Now, the answer, you are tossed between B and then C. But the right answer, okay, the right answer is C. Tracheal deviation is not an early sign of tension pneumothorax. It is a late sign of tension pneumothorax. Okay. You know, when the air begins to pile up, or when the area begins to fill up with the air before the deviation begins to come in. So initially, you may not see the deviation, okay? But as and when the air begins to pile up, I mean, the air keeps on increasing in volume, that is when the deviation begins to come, okay? So usually, in the initial phases, so attention pneumothorax, tracheal deviation is an early sign. It's wrong. It's rather wrong, right? It's C. Sorry, it is a late sign. Okay. That was what I'm trying to say. So the answer is rather B. Okay. The only correct statement about tension is option B. Option A is wrong because this condition happens when an opening in the pleural space creates a one-way valve, which causes pressure to build up in the space, leading to shifting. Option C is wrong because tension pneumothorax is a late sign. That was what I was trying to say. Okay, so that statement is not correct. That tracheal deviation is an early sign of tension pneumothorax. Okay, So I was interchanging it rather. So tracheal deviation is a late sign, not an early sign. The air must what pile up at a point in time before the deviation begins to set in. Okay, so that answer is not correct. Okay, so those who pick the C, that is why. Okay, it will take time before the deviation will come in. Okay, so the right answer is B rather. Okay, I think I was trying to interchange it. Good. So B is a right answer. So option C is wrong because trigger deviation is a late sign, not an early sign of tension pneumothorax. Okay, that option D is wrong because not only open pneumothorax can cause tension pneumothorax, but a closed or spontaneous pneumothorax can as well cause it. Are we on the same page? Yes, we are all on the same page. So the right answer is B. Okay, good. I think the last question. Can someone read, please?
A patient receiving treatment for a pneumothorax calls on the call line to tell you something is wrong with their chest tube. When you arrive to the room, you know that the drainage system has fallen on its side and there is a large crack in the system. What is your next priority? A. Place the patient in supine position and clamp the tubing. B. Notify the physician immediately. C. Disconnect the drainage system and get a new one. D. Disconnect the tubing from the drainage system and insert the tubing 1 inch into a bottle of sterile water and obtain a new system.
Yes, good. So the right answer here, yes, I'm seeing D here, D here, D here, D here, D here, D here. Okay, so D all the time, D all the time, right? A patient receiving treatment for pneumothorax across the line and tells you there is something wrong with their chest tube. When you arrive, you note that the drainage system has fallen on the side and there's a large crack. What's the next priority? Disconnect the tubing from the drainage system and insert tubing 1 inch tester about and obtain a new system. Okay, so the answer is this one. We don't waste time. Okay, well explained. Okay, so this one, the one who asked the question, you see this one, they didn't ask whether contaminated or not. Okay, so please, in that instance, just pick the sterile bottled water and you are good to go. Okay, so the new system needs to be obtained. However, in order to maintain a water seal, until the new system arrives, you need to place the tube 1 inch into a sterile water to regain the water seal. Okay, all right, so we are done with pneumothorax and we are going to begin with tuberculosis. Okay, all right, please, any question, final question, if you have any final question on pneumothorax, whilst we start tuberculosis, you can ask. We are okay, right? We are okay, so we can start with tuberculosis. Very good. So please, that question, this one, the answer is B. If you see somewhere, don't go and pick C. Okay. I was given the right explanation, but the choice I picked earlier on was not that choice. Okay. So the answer is B. Attention pneumothorax is a medical emergency. I know most people would like to choose the C, but then we established that tracheal deviation is a late sign. Okay, it's a late sign because initially the air will begin to build up. Then when the volume increases, that is when the tracheal deviation will begin to set in. So please take note, the right answer is B rather, not C. All right, that's fine. Okay, good. Yes, madam patient, yes.
So please, with the second question that we solved, I didn't get it. The SACA.
Which one? Why? Why didn't you get? Is it a rationale or what?
With the answers, yes, please.
The answer is A, B, D, and F. The reason why it is A, B, D, and F is that, let's take note. I explained that the other time that when you are having tension pneumothorax, mind you, there is what? There is D is obvious. There's going to be tracheal deviation because when the air builds up, it will begin to push what? Mediastinal structures, including the trachea. So that one is included, right? Then tachypnea. Patient is having difficulty in breathing because the lung is not expanding. The lungs are not expanding to help with what? Breathing. Are you getting the point? The lungs are not expanding to help with what? Breathing. Are you getting my point? The lung is not
Yes,
expanding to help with the breathing. So the patient to compensate, that compensating mechanism will cause what? Tachypnea. Are you getting the point? That
yes.
mechanism will cause the tachypnea. Very good. So D and F well explained. Now A and B, I explained there is pressure in the thoracic region due to the pressure in the pleural space. The air keeps on building up. It keeps on inflating. The lung keeps on inflating. It keeps on building up, keeps on increasing in size. Like a balloon, you blow air into a balloon. The size keeps on increasing. So at a point in time, that size of the air or the volume of the air begins to put pressure on other structures in the thoracic cavity, including the vena caves. And then mind you, before blood will enter the heart for circulation, it starts from the vena caves to the right atrium to the right ventricle. So that compression on the vena caves will reduce the amount of blood going into the heart for circulation. This will lead to decreased cardiac output and then hypotension. And then mind you, the vena caves extends upwards. Okay, extends upward. You have the jugular veins and the rest around the same cavity. The vena cavity, the jugular veins, and the rest around the same cavity. So when there's pressure there, it will also increase pressure in the jugular vein, and then the back. Even if there's pressure, mind you, even if there's pressure in the inferior vena caves, the blood begins to backflow. It will increase pressure. Just imagine a patient with right-sided heart failure. What happens? The blood backflow, and you're getting jugular vein distensions. Okay, so when there's pressure compressing the vena caves, the blood will not really go. It begins to leak out to surrounding blood vessels. It can increase distensions or pressure in the jugular vein. That is why you're getting tubular vein distension. Okay. All right. That's fine. Good. Madam Sylvia, what are you saying? So please, among the options, which one is an early sign? Like here, this one, like this. Do you mean these particular options or what? Yes. Do you mean okay? So you mean all right. So usually, exactly. Usually, the earliest signs is the tachypnea. At that stage, the patient is trying to compensate because the lung is not expanding. Okay. So usually, the earliest signs is tachypnea. With respect to these signs, and even not regarding these signs as well, like the earliest signs of what of tension pneumothorax, the tachypnea, when the patient now begins to come because at that moment you begin to what pant for air. Okay. So this the fast breathing, the shallow breathing. I mean that's fast tachypnea. You know, I'm going to see that because the patient tries to compensate. Okay. All right. Good. So tuberculosis, right? Tuberculosis, TB. Actually, you know, TB, when it comes to NCLEX, okay, or you are picking NCLEX, TB falls under what? Infectious diseases, right? Yes. It's not really, I mean, it's not directly related to respiratory system or respirology. It's not directly related to respirology. Okay, TB falls under infectious diseases. But you know, I thought it twice to just chip this in, okay, because it is common on the ankles. TB is very, very common on the ankles, okay. So I just decided to chip this in. And also, it affects the lungs as well, okay. It affects the lungs as well. That is why I just want us to treat it. Just refresh our mind on TB, okay. All right, so we are zooming into TB, okay, right, for today. We are beginning with tuberculosis. Please let's pay attention. If there is any additions, any contribution, you can raise your hand or any prompting like any correction that you want to make. Please, you raise your hand and then I'll call you in and you make your corrections. I mean, if I made a mistake or something, okay, or anything, your contribution, then we move ahead. Okay, all right. So when we say tuberculosis, what is tuberculosis? It is a bacterial infection caused by Mycobacterium tuberculosis that primarily affects the lungs. Okay, it is a bacterial infection caused by Mycobacterium tuberculosis that primarily affects the lungs. It is a bacterial infection caused by Mycobacterium tuberculosis that primarily affects the lungs. Now, in TB, you know, the definition is simple like this. It is caused by Mycobacterium tuberculosis, right? Now, how do a patient or what is the process of getting TB or being infected with tuberculosis? This is what occurs. Now, a person or someone with the bacteria, someone with the bacteria being infected with the bacteria will cough, okay, will sneeze. Sometimes they even say laughing can cause the bacteria to be released into the airways, okay, or released to the air, okay. So some of the bacteria will cough, will sneeze, will talk, will laugh. Now, the moment this occurs, probably the patient did not adhere to the treatment, but it doesn't cover the mouth or something like that. So the bacteria had its way into the airway or into the air. Okay. Now, mind you, one thing about this bacteria is that it is very, very light. So it can stay in the air for some time or for a longer period of time. Okay. So please take that is the reason why tuberculosis is an airborne transmission disease. Okay, it's an airborne transmission. The bacteria is very, very light in weight. It can sustain in the air for long. Okay, that is why if a patient have TB, you close their room. They should be in a room closed. Because even if you open the door and the patient coughs, the bacteria can stay in the air for long. Any person passing by can inhale the bacteria and can get the disease. Are you getting the point? So it is airborne. The bacteria is very, very easy. So when a patient cough, sneeze, talk or laugh, the bacteria is being released into the airway or into the air. Then someone will inhale it. The moment a person inhales the bacteria, now the bacteria finds its way into the airway, right? It begins to attack the lungs. Now, once there is a bacteria in the airway, in the lungs, inflammatory process begins to occur. Okay, inflammatory process begins to occur. So the body will release inflammatory substances, mediators, including cytokines and granulomas. Okay, including cytokines and granulomas. Now, mind you, if your immune system is very, very strong, these inflammatory mediators, especially the immune granulomas, can encapsulate the bacteria. It can lock it somewhere to the point that it cannot spread to attack you. This is when you become latent TB. Okay, so you have been exposed to the bacteria, you inhaled it all right, but because your immune system is strong, after the inflammatory process and there's release of immune granulomas, they were able to capture the bacteria and then prevent it from spreading. So it becomes what? A latent TB. Now, when your immune system is weak, for example, in a patient with HIV, immunocompromised, a patient who is taking chemotherapy, a patient taking steroid, okay, weakened immune system, at that point, there is a weak immune system to what? To encapsulate the bacteria or to lock the bacteria and corner it. So they begin to spread and they begin to cause what? Tuberculosis. Hence, you begin to see signs and symptoms like low-grade fever, chills, and coughing. That is what occurs in tuberculosis. So you just inhale the bacteria find its way into the airway, inflammatory process begins to occur, and if your immune system is strong, fine, you are good to go. But if your immune system is not that strong, the bacteria begins to spread and then it begins to attack every area in the lungs. And then sometimes it can extend beyond the lungs, can attack, those joints and others, the spine, the kidney, the brains, and the rest, okay? So that is that for mycobacterium. Now, mind you, because of the inflammatory process in the lungs, patient begins to cough, begins to have some, sputum production, like mucus productions, there can be fever. All this is because of the inflammatory processes that occurs, okay? So that is something you should know for mycobacteria or tuberculosis. We have types of TB. We have the pulmonary TB affecting the lungs. This is the primary type of TB, the most common one of tuberculosis, right? The most common one. We have the pulmonary TB affect the lungs. Then we have the extra pulmonary TB. Extra pulmonary TB. Okay, is my class being recorded? Yeah. Okay. All right. Extra pulmonary TB. Okay. Extra pulmonary TB. This one affects other parts of the body, such as the kidney, the spine, and the brain. Okay, the kidneys, the spine, and then the brain. Then 3, latent TB. The bacteria are present in the body, but the individual is not sick and cannot spread the disease, meaning that your immune system is strong. But you'll be learning very soon, okay? You'll be learning very, very soon that if you have the latent bacteria, you still need treatment, because if you don't treat it, it can become an active TB, okay? So when you are exposed to the bacteria and then you don't show any sign and symptom because of a strong immune system, the latent TB, we term it as latent TB, right? Good. Then 4, active TB disease. The bacteria multiply and cause symptoms, okay? So the patient becomes sick now, and then we term it as active tuberculosis. Now, the mode of transmission, TB is spread through the air when an infected person coughs, sneezes, or talks. So it's an airborne transmission, okay? It's airborne, right? Very good. Yes. Any question on this slide? All right, good. I think there's no question, right? Good. So what are some of the risk factors? What are some of the risk factors of tuberculosis? Cause the risk factors. So 1, when an infected person sneezes, coughs, talks, or laughs, okay? When an infected person coughs, sneezes, talks, or laughs, okay, this becomes a risk factor for tuberculosis, okay? All right, so Mr. Kabiru said, do we have viral tuberculosis? Oh, tuberculosis is caused by bacteria, not viruses, okay? So as the name goes, Mycobacterium tuberculosis is a bacteria. Okay, it's a bacteria. All right. Okay, all right. TB is not a virus, it's a bacteria. It's caused by a specific bacteria, to be precise. Okay, specific bacteria, Mycobacterium tuberculosis. Right. So when an infected person coughs, sneezes, or laughs, it can lead to what? TB. Then 2, immunosuppression. As I said, immunosuppression. When you are HIV positive, you don't take your medication, so your viral load keeps on increasing. You are under chemotherapy for cancer, okay, or you are taking steroids. All this will diminish your immune system or suppress it. So it becomes difficult for the immune system to fight the bacteria when you inhale it, okay, and it can put you at risk for getting tuberculosis. 3, recent travel from endemic areas. And as an example, you went to a particular area, there was tuberculosis outbreak, okay, there was tuberculosis outbreak in the area, right? There was TB outbreak in the area. You can be at risk for getting tuberculosis as well. 4, exposure to active TB infections. Like if someone cough and you are exposed to it, it puts you at risk for getting tuberculosis. 5, resident or employee of a prison, homeless shelter, or healthcare facility. So just being a resident or an employee of a prison, you know how prison, they are overcrowded. You get it? 20 people in a particular, just a small, there's poor aeration. I mean, there's no amount of air going there. When someone coughs with TB, you are going to get it easily. Okay? You are easily going to get it. Just simple like that. Or you are in a homeless shelter, okay? Or you work in a healthcare, like we in the RNs. If you're an RN, you work in a healthcare facility, people come with tuberculosis, they cough, they sneeze, they are here doing this here and there. It can put you at risk for getting tuberculosis. Okay. Yes, even boarding school, yes, someone's just type it in the chat box. Even boarding school, yes, they are all part. Okay. Even boarding school, right? Then 6, substance abuse, like alcohol. Okay. Like those who drink alcohol a lot, and then even those IV drug users, those who inject themselves all the time with drugs and all this stuff, are also at risk for getting what? Tuberculosis. And then 7, children are at higher risk for also getting tuberculosis. Why? Because in children, their immune system is very, very, I mean, they are now building themselves. They don't have a strong immune system. If you're a child, you don't have a strong immune system, okay? So if you go closer to a patient with TB and a patient coughs, please, a child, you are going to get it simple, because you don't have a strong immune system, okay? So these are some risk factors. You may see a question on your NCLEX. A patient, a 55-year-old man, I like 55-year-old, right? A 30-year-old male patient was admitted to the ER, or it was on a medical unit, floor 2, right? Good, floor 2. And then you started seeing symptoms like chills, night sweat, fever. Don't be confused. Don't get confused, okay? And then they added the patient was sleeping in a homeless shelter. Please, when you see some of these things, if you start thinking about TB, I have observed from several kill banks, okay, if the question is on TB, most at times they will attack something like a homeless shelter, or the patient just traveled from an endemic area, okay, or the person was in a prison or something like that. Please take note. Once you see those things, they start prompting you, okay? They start prompting you that the patient is having tuberculosis. Then you add other stuff like diagnostic investigations and other stuff to confirm that the patient has TB, because as the signs and symptoms of TB is similar to a particular condition, okay? The Hodgkin's lymphoma, the cancer of the lymphatic system. When you have Hodgkin's lymphoma, the patient will present similar symptoms like TB, night sweat, chills. It's very, very similar. Okay, so when you see those things, some of the things that should prompt you that this is TB is what I spoke about, the homeless shelter. They usually bring those things for you to see, travel from endemic area, or the diagnostic investigations to prompt you. Okay, very good. So let's always be on alert to not confuse ourselves on the English. Right. So these are some risk factors for tuberculosis. Okay. All right. Good. So now the signs and symptoms. Signs and symptoms of tuberculosis. We have the latent and then the active. So on my screen, you could see something in brackets. 5 to 10% develops active TB if not treated. So don't be there and say that you have a strong immune system. For you there, you eat better food, you are here, you eat fruit and stuff, so you have a strong immune system. So even if you go to a patient room without a mask, like an N95 mask, oh Charlie, I have a strong immune system. Even if I get latent TB, I'll be fine. Please take note, 5 to 10% of people who develop latent TB are likely to get active TB. Okay, 5 to 10 people who get latent TB, the percentage are most likely to get active TB. Okay, if not treated. So please, in as much as the latent TB, you don't have symptoms, you don't have what do you call it? I mean, you are not sick, you don't show this, you can't even transfer. Please, you must still take medications like isoniazid. Okay, you can still take them to prevent it from extending to active TB. Now, these are some of the things you should know for latent TB. They are non-infectious. Okay, they are non-infectious. They can't transmit, and they are asymptomatic. They will not present. Oh, they are asymptomatic. There's nothing like fever, chills, or whatever. They are asymptomatic. Okay. Then lastly, they will have a positive PPD and a positive blood test if we test for TB. That is something cardinal about latent TB. So please take note when you take when you do a skin mantles test for a patient and a patient have a positive PPD or a positive skin mantles test, you will learn it very soon. What makes you positive and what makes you negative when you do the skin test. But please take note, when you do the test and the patient have positive skin mantles test, please, it doesn't end there, because even if you are exposed to the TB, you still have a positive PPD. So you go ahead and do a chest x-ray and a sputum culture. And then please mind you, among all the tests we do for TB, it is the sputum culture that stands top, gives us a definite determinant for TB diagnosis. Okay, it is believed, or according to science, or it is believed that the sputum cultures gives us or stands tall when it comes to other diagnostic investigations, the most definite one for TB. Okay, so if a patient tests positive for PPD and blood test, please don't conclude over there simply because the patient is positive for the skin mantles test or blood test, the patient has TB. No, once you are exposed to it, you have positive, so you must go further for sputum and then what, and then chest x-rays. Are you getting my point? Very good. Now, because latent will not have symptoms, if a patient has TB and they're having symptoms, because it seems simply that this is what an active TB. Okay, if a patient tests positive for PPD, positive for sputum, and they're having symptoms, this is a clear sign the patient is having active TB. So in active TB, what do they present with? Coughing. So a persistent cough, often producing mucus or phlegm. I have explained since we started this respiratory system that the reason why patients coughs a lot in respiratory conditions, right? Because there's inflammation. Inflammatory process is going on. Mucus production is occurring. There's mucus production going on here and there. So in an attempt, the body will try to compensate. So in an attempt to bring the mucus out, the patient begins to cough. So they begin to cough here and there, okay? So they have coughing, a persistent cough, often producing mucus or phlegms. Then 2, fever. Their fever is a low-grade fever. Please, in TB, their fever is a low-grade fever, not a high-grade fever. So you check their temperature and sometimes it's just a little above normal. They don't really go high. Okay, it is a low-grade fever. The reason is because, when you have the bacteria in your lungs and the inflammatory process begins, the inflammatory process will cause the fever because inflammation comes with fever, warmth, and all those stuff. Okay, so you're going to be warm, you're going to be fever. But one thing is that the inflammatory or immune granulomas can encapsulate the bacteria to the point that the bacteria does not have its free flow. Okay, so that alone does not give the bacteria that chance to penetrate the body to cause that high fever. This is because of the immune granulomas. It begins to compress or shrink the bacteria, so the fever becomes a low-grade fever. Okay, this is all the work of what the immune system. Okay, the work of the immune system. The immune system is trying every means to help reduce the bacteria. Okay, right, good. What is PPD? We will get it very soon, but PPD is purified protein derivative. Okay, purified protein derivatives. We'll get there very soon. I'll explain more or talk more about it. Okay. All right. Good. So we have low grade fever. Then 3, weight loss, unintentional weight loss, and loss of appetite. Okay. Someone who's having TB, there's kind of the bacterial inflammatory processes going on. Okay. So it's going to be kind of nausea, loss of appetite, and this will prevent the patient from eating a lot. Okay. So they are going to get what? Unintentional weight loss. And then mind you, we've learned something from COPD, from asthma. What did we learn? We learned that when a patient is having issues with their breathing, because your energy is needed when you are eating, there's going to be increase in oxygen demand. That alone will not let the patient eat a lot. So eventually, weight loss will begin to set in. Are you getting the point? Yes, because there's limited oxygen, and TB will attack your lungs. And anytime the lungs are affected, oxygenation becomes a problem. Okay, oxygenation becomes a problem. So you don't get that liberty, that energy to eat. You get it, and then it begins to drop. Okay, so you are going to run into what? Weight loss. Then night sweat. Someone may find out or may ask, why do TB patients have night sweat and not daytime sweat? Why night and then not daytime? Okay, so usually it is because of the changes in the body normal temperature. Mind you, anytime you're having fever, the body will try to compensate by sweating. Are you getting my point? When you are warm, when you are having, you are warm to touch, the body will try to sweat to what? Take away heat away. You have several ways of heat conduction, right? Yes, so we can just read around those things, right? So it's the same idea. So there you are warm to touch, you are having fever, you are warm. The body trying to what? Compensate by sweating so that there can be some heat loss. Okay, but mind you, in the night your body is cool than the day. During the day your temperature is a bit high, but in the night the temperature is low. Okay, in the night the temperature is low. So when the temperature is low and the fever and the inflammatory process cause the fever at night, the body compensatory way to produce the sweating and to remove the heat will begin to cause too much sweat. Okay, the reason why you don't have too much because the temperature is a bit high already. Okay, the temperature is a bit high already, so the fever is already coming to meet a high temperature, so the sweating is minimal. But in the night the body temperature is low, right? So to compensate hardly to produce the sweat, they produce more at night. Okay, that is why they have night sweat. I get my point. Good. Then fever is there. Obviously, you are going to get chills. Okay, if you're having fever, you are going to have chills. Okay. 6. 9 sweat, the same thing I explained. Then 7, chest pain. All right. So we've learned this also since we started the respiratory system. Anytime there's something wrong with your lungs, because your lung is just beneath your chest, sometimes the pain can radiate to the lungs and you're going to the chest and you're going to get chest pains. Okay, that is something you should know for the signs and symptoms of tuberculosis. Please, any question on this slide? Any question on this slide? All right, I think we are good to go. Please, if you have a question, you can raise your hand though, so that I unmute you, then you speak. Okay. All right, good. Then how to diagnose tuberculosis? Please, these areas are NCLEX areas, especially the skin mantles test. They are NCLEX areas, so please let's pay attention. Okay. All right. So one way to diagnose TB. Okay, I see a hand up. And I'm Angelina. Please, you can unmute and speak. I'm Angelina, you can unmute and speak. Okay, Madam Doris, you can unmute. Madam Doris, you can unmute.
Yes, sir. So does it mean that even in the lancet stage, the patient can still infect someone?
No. Clearly on my screen, they are not infectious. Okay, please, can you see on my screen? Read under latent. Sorry. They are not infectious. Okay, are you there? All right. Is it Madam Obapa May? Yes, you can speak.
Yeah, but okay, just to add a little point to what you said about the night sweats.
Okay,
The bacteria, they are very active during the night.
okay.
That is when they are active and they are working, like causing all those harms. So the body or the system in turn um institute its way to compensate. So that is when the sweat comes about. And with the sputum too, it is not taken at any other time of the day except in the dawn, like from 4 to 6 a.m. because that is when the bacteria is very active. So, and we want to capture it if they are present in there. So when it's taking that time um during the test, we can identify them properly. Yes. So just to add up. Thank
Very
you.
good. Yeah, very good. All right. Madam Angelina, yes, you can unmute and speak.
Hello, boss.
Yes.
Hello. Yeah, with your science and sentence, I
Mm,
didn't see, but I want to find out.
mm.
Do they have dyspnea? Because there are some questions I see dyspnea
Yes, yes,
with their science. Okay,
yes,
okay,
yes. They are going to
okay.
have okay. These ones, sometimes I try as much as possible, okay,
Mhm.
to try and then focus on the English interest more. Okay.
Okay, okay,
Most of the time that I personally I like that. Okay. I like the ones that common on the ankles because we know that something attacking your lungs, always oxygenation becomes a problem. I think I even said it, right? Good. Oxygenation becomes a problem. Yeah. So obviously the person will have dyspnea. Okay, because if the bacteria stays in your lungs and infects your lung, inflammatory is coming, there is inflammatory process, mucus production. Mucus will block the airway. So the amount of oxygen entering your airway for gaseous exchange to be achieved is not there. So you're going to have dyspnea. Are you getting the point? Yes. So it is there. But we all know, usually some of these things are common. It's conversant with us. When it comes to lungs issue, we know that dyspnea is a common. Any disease attacking the lungs, most of the time dyspnea is common. Okay. So that is why sometimes I reduce those. But thanks for bringing it up. Okay. Thanks up for that. Right. Good. Madam Mary. Yes.
Thank you. Thank you very much. I think at the early part of your presentation, you gave both active and latent, and you said that the latent one, although you are not showing signs and symptoms, but you can spread the bacteria because it's in your blood. That's at the early part of your presentation. There was something like that you wouldn't show signs and symptoms, but you can actively spread the disease because the bacteria is in your body. That
Please, I
was
said
what is there. If you go back, you will see it. It was there.
let me see.
It was there. Then aside that, go back.
Please, if you
I
can
think.
see, can you read again? The bacteria
Oh,
are present but cannot spread the disease.
okay. Then maybe I think I didn't see that. Okay, thank you.
Okay,
But
all right.
there were other sisters who said that early morning. I think this time around they have changed. We are using the gene experts, and you can take it at any time of the day. And any time of the day, you can even store the sputum up to 3 days with ice pack. They've changed the routine way of
I'll
doing
get
it.
there. I'll get very soon. Let's put I'll get there very
So,
soon.
people were saying
Okay.
the early morning have stopped.
Don't
Anytime you can
worry.
take it. One client is
Okay.
available.
I'll get there very soon,
Thank
Madam Mary. Okay, I'll talk later about the early morning this thing. Okay. All right. Madam Angelina, sorry, Madam, is it Abna D?
Okay, sir.
Mhm.
Hello.
Yes,
Network.
I'm here. I'm here.
Please, when this is something I want to ask, maybe it might come the time somebody writes the english. When you come
Okay.
to the US and you go and test
Mm-hmm.
for TB, mostly the latent TB is positive. When you ask them, they will tell you that those of us from Abia, Ghana, or some countries, because of some vaccination we take, so because of that, you see, whenever we test for that latent TB, it is positive. So I don't know whether you've seen in NCLEX exam that maybe somebody is from, they've been using words like custodian, or say, then there's maybe Africa or some part of Africa, and maybe the person tested for latent TB, which is positive, yeah. And what could be the reason? Can you have that connection for us? Because I didn't really understand them when they said that.
Okay. So we have a vaccine to
Connection
prevent TB.
but
We
that's
have a
why when you test for
yes, we have a vaccine. We have a vaccine to give that prevent TB. We call it the BCG, the Bacillus calmette growing. Okay, the BCG vaccine we give. Okay, you can take it, to prevent tuberculosis. Okay, and now, please, if someone takes this vaccine and then you check the PPD, the skin mantle test, and it's positive, we call it a false positive result. Okay, because the vaccine, when you give a vaccine, what happens? You are introducing an antigen to the patient's body. Okay, so the patient already has been exposed to the TB bacteria in some way. Okay, in some way. So that will give you a false positive. That is the reason why we are getting that false positive results. You get it? So when you receive the bacillus, the bacillus calmette growing, in some way you have been introduced to the patient the TB bacteria. Okay, they're like antigen of the bacteria. So you inject into the skin, so you've been exposed to it already through the vaccine. So when you check the PPD, you still are going to have a positive result, but we term it as a false positive because you took the vaccine. Are you getting my point? Yeah. So that is it. Okay. All right. So you want to speak when I'm about me? Yeah.
Yeah, Bosaki, thank you. I get your point, but what if they use blood sample and you test positive, but then you have had the BCG already? That one to
Usually, they are all 10 false positive. Okay, because once you have gotten the vaccine, we believe or we know that you have been exposed to the antigen. Okay, so you can test positive, but then because of the vaccination, it becomes a false positive. Okay. Right. Yes.
Okay,
That
thank
is
you.
something you should know for your English. Yes. Madam Sarah, yes, kindly speak before Madam Taku comes in. Madam Sarah, you cannot mute.
Yes. Okay. So I was asking, you said when someone takes someone has taken the BCG, is the person taking can it be taken twice? Because the BCG is taken at birth. So when we are traveling, do we have to take another BCG? Otherwise, then all of us will become latent TB carriers because
Usually,
for
you
the
don't take
Africans,
twice. Okay, usually it's once. Okay, usually it's once. If you are latent TB, just take, for example, if they test you and then you are latent or you find a latent TB, to prevent active TB, you can be on the medication because BCG is generally not given twice. It's given only once. Okay, Madam, is it Abna? You want to speak? Please, you can read on, but please let me make this disclaimer. Okay, please, we are all bringing ideas anyway and discussing things pertaining to our, TB and the rest. But please, let's try and streamline. Let's try and streamline the questions towards English areas. Okay, sometimes some questions are not really pertaining to the English. Okay, and they might not really ask you on the English so that we can move a bit faster. Okay, all right, yes, Madam, is it Jumia? Taku, please, you can speak.
Yeah, good evening, boss.
Evening.
Since you just made mention of the father, let's focus on the NCLEX. I think I'll just keep my question because it was based on cities, the question the others have just asked.
Okay. All right. Thank you. Right. So those the question that came up concerning the those that came up concerning the someone is asking the chat box, how will I know the English questions? The English question is what we are discussing. Okay, like the ones you see on my slide, the one we are discussing. These are the English questions. Some questions like can the BCG be taken twice and other stuff? Sometimes they don't really ask about those questions. Okay. When it comes to, let me make it clear. When it comes to TB and diagnostic investigations, the question that was raised about the false positive is a bit key. Okay, so because they are giving the vaccine, we are going to have false positive because they have been exposed to the bacteria, an antigen. So the bacteria is kind of in your skin already. Okay, so that is something you should just know. Okay, but I mean, there are some of them you don't really have to pay attention to when it comes to anything. Okay, all right, good. Please, any further question? Please, is there any discovery where urine sample is taken to test TB? Hey, be taken to test TB. Okay, so for our that is some of these questions. Mr. You raise your hand. You can raise your hand. Okay, so urine can also be used to test TB. Okay, from new development that is coming. Okay, but please, for our English sake, use just so. For example, if you meet a question like this, a patient, is on your ward or blah blah blah. Which of the following ways can you test for TB? Okay, which of the following ways can you test the TB? You can pick urine, sputum, blood. It's correct. But most of the time, the NCLEX, they ask about the skin test, the chest X-rays, and the sputums. Okay, most of the times about these three. Okay, all right. But urine can be used as well. Please don't get me wrong. Okay, urine can be, what do you call it? Used. Okay, to test for TB as well. All right. Please, we are discussing tuberculosis now. Okay, we are discussing tuberculosis, the diagnostic investigations. Okay, so I think we can move on, right? Yes. We can move on. So on my screen, we see the Matthews tuberculin skin test. Okay, the Matthews tuberculin skin test. A skin test. Now, what do we do, or what do we use this for? Where do we use this for? Okay, what do we use this for? It is a skin test that measures the body's exposure to TB. This test just measures your body exposure to the TB. Okay, it just measures the body's exposure to the TB. Are you getting me? Yes, just that. Okay, just that. It just measures the body exposure to the TB. So, how do you? I see 2 hands raised. Kabiri, what do you want to say? Yes, I've unmuted you. Kabiri, you can speak.
Okay. Bosaki, please remind me about the root and then the angle for the TST. It is
Okay.
usually asked.
Okay. All right. So that's what we wanted to ask then. That's what we wanted to ask, right?
Yeah. The root and then the angle.
Okay.
The root is given an angle. Yeah.
Sure. I'll talk about it very soon. Okay. All right. So perfectly. So let's zoom into it. Tuberculin skin test. Good. So at a skin test that measures the body's exposure to TB. Okay. Now, how do we do this test? You inject the PPD. The PPD, we call it purified protein derivative. It is like a protein substance, okay? They will inject it into the skin. Now, where particularly into the skin? They can ask on English, as Mr. Yusuf just brought up. They will inject into the intradermal space, into the dermis. So when you see intradermal, the right answer, please, it is not into the epidermis, not into the subcutaneous region. No, it is injected into the dermis, intradermal, at 5 to 15 degrees. At 5 to 15 degrees angle to the skin. Please take note, at 5 to 15 degrees angle to the skin. So when they inject this PPD, okay, the name is purified protein derivative. Let me type it in the chat box. Like everyone is asking. They will not even ask about this. But it's good you know anyway. Purified protein derivative, okay. Purified protein derivative. So they will inject this thing into the skin, into the intradermal space, the dermis, at 5 to 15 angle degrees. Okay, I mean on the skin. Now, when they inject this into the skin, you will have to go back home. If you are not on the ward, like a patient is not an inpatient, the patient can go home and come back within 48 to 72 hours, like 2 to 3 days. When the patient comes back, this is what we are going to expect to be positive. We are expecting induration, not redness. Because do you know, when you inject the patient's skin, there can be redness. But please take note, if you see redness without the induration, it is not a positive result. You must see induration to indicate a positive test for skin mantle test. Let me show a picture of the, what do you call it? Of the induration. Let me try and see if I can show a picture of the induration so that we see it right away. Okay. Yeah. So you must see the induration, not redness. If you see redness, sometimes the NCLEX can confuse you. A patient is exposed to TB. Okay. Is exposed to TB and the skin mantle test was done. After 48 hours, the nurse assessed and saw redness. Is this a sign of a positive? It is not a sign. You should rather see induration, not redness. If you see redness, redness is out. Okay, redness alone is out. If you see induration, okay, like a bleb. Sometimes they use bleb, sometimes they use induration. Okay, sometimes they use induration, they use bleb. So any of these, okay, is a sign that you are having tuberculosis. Okay, I think I'm seeing some here. Let me try and see. Can you see my screen? Have you seen this round thing over here? Hello, can you see my screen? Hello, can you see my screen, please? Or you can't? All right. So we are seeing the induration there. Okay. The induration, that round thing over there, indicates that we are getting a positive result. Okay. You don't have to see redness alone to conclude that the patient is positive. No. If you see redness alone and conclude, you are making a wrong diagnosis. You should rather see induration or bleb, B-L-E-B, bleb, or induration to conclude now. Okay, induration or bleb. All right, good. So that is something you should expect on the NCLEX, induration or bleb, no redness. Okay, to conclude that the patient is having tuberculosis. Okay, all right. Okay. All right. So that is that. So you inject the purified protein derivative there. You allow the patient, or you allow for 48 to 72 hours. Yeah. Yes. So someone is saying it's like the same what happens when someone is being given the BCG. Yes, because the BCG is like you have been exposed to the antigen. Okay. Like an exposure. The same way, because this skin mantle test is used to measure your body exposure to the TB, the bacteria. So it's almost the same. Okay. Yes, it's almost the same. Yeah. Good. So inject the PPD into the skin, allow for 48 to 72 hours. Now, you are expecting induration, not redness, to indicate a positive test, meaning exposure to the TB. Now, here is where the focus is on the NCLEX. The normal range should be between 5 to 15 millimeters. Okay. When you measure, I'm sure when the picture came, you saw some ruler under the bleb, right? We also some kind of a ruler under the bleb. So the normal range is 5 to 15 millimeters. Okay. The normal range is 5 to 15 millimeters. Now, when you inject the PPD into the patient's skin, you wait after 48 hours, and the patient recording is 5 millimeters, and then the patient is an immunocompromised patient. or the patient is on chemotherapy, or the patient is taking steroid, or the patient has undergone organ transplant, please, it is positive. When the patient is an immunocompromised patient undergoing chemotherapy, anything that will suppress the immune system, and then you just see a recording of 5 millimeters, it is positive. Okay, it is positive. When the patient is a health worker, a drug user, or a child, please, you are expecting 10 millimeters. And then when the patient is a healthy, like someone who is healthy, okay, without any like immunocompromisation, the patient is not a health worker, it's not a child, now patient, you should rather expect 15 millimeters, okay? Because we, the reason is that, if you're immunocompromised, your immune system is weak. So you don't have to wait till 5. So you don't have to wait till even 10 to diagnose you. Once we see 5, we can diagnose you. You don't have to wait till 10. Once we see 5, we can diagnose you of having TB. And then if you're a health worker, we are exposed, as I said, you enter TB patients room here and there. So for you to 10, you don't have to get to 15. Just 10 can conclude that you've been exposed to the TB bacteria. Then 15 is a healthy patient, someone who doesn't work at the hospital, it's not a prisoner, it's not at homeless, the patient is not even compromised. For them, we are expecting 15 millimeters for a healthy patient. Now, I have a question. What if the patient record 8 millimeters? Where does the patient fall? Is it positive or negative? 8 millimeters. Yes, who will answer? 8 millimeters. You check the skin mantle test, it is 8 millimeters. What does it mean?
Hello.
Yes.
Hello.
American.
If the client is an immunocompromised, it's still positive. You have ranged it. You take 5.
Yes.
So immunocompromised meaning 5 to 15. The client is always positive. If it is a health worker, it's 10 to the 15. Then if it's healthy individuals, it's 15 millimeters. If it's less, yes. If it's less, then you are not determined. So it depends on the situation of the client. That will help you to know if the client is negative or positive. Thank you.
So sometimes the NCLEX can trick you. So please listen to this. Okay, sometimes they can trick you. They will bring a health worker, someone who work at a hospital. Okay, exactly. Someone just commented it in the chat box. Positive for at-risk patient and negative for healthy patient. Okay, let me further explain. Okay, so when you check and it's 8 millimeters, don't let the English trick you. If it is a health worker, it's negative. Please take note. If it is a health worker, for a health worker, we must get 10 and above. So if you check and the question states a skin mantle test was done on a health worker and you record 8 millimeters, it is negative. The patient is not exposed to the material. But if it is an immunocompromised patient, it's positive because for them you are expecting 5 and above. Okay, are we on the same page? Same way. If the NCLEX try to treat you and bring 12 for a healthy patient, it is still negative. 12 should be positive for immunocompromised and health workers, but for healthy patients, it should be 15 and above. Okay, so please always read the questions very well. Don't be in a haste. Once you see the value 5 or once you see 8, 8 there is health worker. Please take note. If they give you 12 millimeters and they put the healthy patient, it is wrong. It is negative. It is positive only when it is 50 millimeters in a healthy individual. Are we there? Are we on the same page? Right. So that is something you should take note of. So that is what you should know for the skin mantle test. They inject what? PPD, purified protein derivative, where? Into the dermis. At what angle? 5 to 15 degree angle to the skin. Okay. What are we expecting? Induration, not redness. It is 5 for immunocompromised, 10 for health workers, 15 for healthy individuals. Just know this for the English. We are good to go. Okay. Madam Mary, do you have anything to say?
Yes, I want to clarify something.
Okay.
I think I met a question somewhere and they said that if a client is having the induration, let's say, okay, it's positive mantle test. Is the client having TB? I think I chose that, yes, the client is having, and they said no. Even somebody, those who have ever been treated TB can have a positive test. So when there's positive test, you have to go ahead to confirm with the sputum and that of the X-ray. So
Yes,
that's
I
what
think
I
I
want.
said it. Yes, yeah, very, very good for the re-echoing. Okay, yes. But I said this earlier, if you were following. Right. So that is that, okay, for the skin mantle test. Then two, you do the interferon gamma release assays. Yeah, Madam Tina. Yes, you can speak. I've unmuted you, you can speak. You can unmute and speak, Madam Tina.
Please, I want to find when you inject the PPD, you will not get any
Yes, less
induration. And
likely.
if there's no induration, what does that mean?
It's negative. If there's no indication, it's negative. It means that you have not exposed to the bacteria. Okay. Someone,
Okay.
yes, someone, for example, how I just want to give a scenario. Okay, someone, let's say someone who is always in the house, does not go in overcrowded areas, who doesn't expose himself to people. These patients you inject, you're not going to see anything. Okay. So for them, they have not been exposed to the bacteria, so you're not going to see anything. Okay. All right. Or even if you do, and you are seeing like 2 millimeters, all these things are negative, like 4 negative. It means that the person has not been exposed. Okay. So that is something. Right. Good. You're welcome. Yes, Madam Sarah. Yes.
Yes, so when we inject the PPD, how many millimeters should it be? The normal, not the normal range, but when you give, when you inject, when you give the intradermal, what millimeter will it be? So that we can confirm whether it's negative.
Hey, your question. Can you repeat your question?
So you've given a normal range to be 5 to 15. That is when the PPD is given. So when the PPD is given, is it less than 5 millimeters that will tell us that is negative? Like a normal PPD when you give, when what's the diameter? Like what measure? Is it like maybe 2 millimeters that it will expand to the 5? Or is it point something that it will expand to the 5? That is when you get the induration.
Okay, I think I'm getting your point. Yeah, it's like you want to find out the mils of the PPD itself. Right?
Yes.
So the standard dose is it's in units, like I mean 0.1 mil of fluid. The PPD is something small. It is just 0.1 mil. Okay, just 0.1 mil, right? So when we give it, we inject it there, we give an additional, I mean 72 hours, 48 to 72 hours. Okay, for you to be observed, whether it will be 10, 5, 10 or 15 after measuring. So when we measure, depending on the situation at hand, we can diagnose it. But the actual fluid, no, it's just something small. Okay, just something small, 0.1 mil, something small. Okay. All right.
Okay, thank you.
All right. You're welcome. Good. So we can move on, right? Good. So two, you can do the interferon gamma release assays. Okay. This one is a blood test that measures, take note, it measures the immune response to the TB. Okay. The tuberculosis skin testing, the skin test measures what? The body exposure to the TB. Then the interferon gamma release assays measures the immune response to the TB. Okay, good. It measures the immune response to the TB. And then some of the tests that goes under or falls under the interferon, sorry, is the quantiferon TB gold test and the T-spot. Okay, like they are all blood tests being done to check your immune response to the TB. Now, sometimes they will pick this over the skin mantle test. Why? Because the advantage is that this one, you don't have to return. The results will be seen clearly. Okay, or let me say, within some few minutes, okay, you are going to see the results. You don't have to go back and return. Okay, so that is why sometimes they will pick this test over the skin mantle test. Okay, that's the advantage over the skin mantle test. Then three, you can do a chest X-ray. A chest X-ray will identify what? Interstitial infiltrate. Okay, it will identify interstitial infiltrate. Right, good. Then four, you do a sputum smear microscopy. A sputum smear microscopy. Now, here you have to pay attention. I mean, there are some few things you should know for the NCLEX over here. Right, good. So the sputum sample is examined for what? Bacteria, TB bacteria, and then you know the bacteria, we call it Mycobacterium tuberculosis. One other thing we know is that it is an acid fast bacillus. Okay, an acid fast bacillus. okay, an acid-fast bacillus. Now, please take note. One thing that will make us know that you have TB is this sputum test. When you take the sputum and then they place it under a microscope, they want to detect the acid-fast bacillus. Now, how do they detect the acid-fast bacillus? When they begin to see red strands in the mucus, because acid stains red, okay, good. Acid stains red. So when they take your sputum and they want to really test that is this patient having TB, we are looking out for the acid-fast bacillus in the sputum. Let's slide it under a microscope. Now let's observe. Once they begin to see some reddish strands in the mucus, it can help them detect that the patient is having what? Tuberculosis. And then mind you, the sputum cultures, you are taking 3 samples on 3 different days or 3 different occasions. 3 samples on 3 different occasions. Don't use one. You took one for the test. Don't use one. I mean, one is not, I mean, recommended. Usually, it should be a 3 sample. Okay, you take 3 samples on 3 different occasions or days to test for the TB, right? To test for the TB, and then lastly, you can do sputum culture to rule out the causative organism. So please, these are some key diagnostic investigations, okay, that you can do to test a patient with TB. Focus more, or let me say, most of the time, what I see on the NCLEX is really on the Mantoux test and the sputum, okay. So they stain red, right? So if you had a question, a patient with tuberculosis admitted to the medical unit floor, right? Good. It's been tested for tuberculosis, right? So sputum were collected. Which of the following indicates that there was a presence of acid-fast bacillus in the sputum? When you see a reddish strand in the mucus, please take note, reddish strands in the mucus. It's a clear example, okay? It's a clear example of the sputum. I'm saying that the sputum explanation, they will take your samples, 3 different samples on 3 different occasions. They want to test for the presence of an acid-fast bacillus, which will be observed by or with red strands. Let me see something. Let me see if I can show something on my screen for you to see. What do you call it? Is it acid fast bacillus? Acid fast bacillus thing. So good. These are some pictures. Okay. Good. So let me use this. Are you seeing this thing? Please, can you see the picture?
No picture is showing.
Oh, can't see it. Oh, sorry, let me see. Are you seeing it now, please?
No, diagnosis is showing. You are showing the notes.
The diagnosis is oh,
Yeah.
okay. Let me check this. Okay. Please kindly hold on. Forgive me for the delay. Oh, I see. That's fine. Please, have you seen this screen? Have you seen? I'm sure it's on the screen now.
Yes, it's showing now.
So you see the sputum. The sputum is the one that looks like a cloud. You know how sputum looks like. You've all seen sputum before. So when you slide the sputum under a microscope, right, to test for the active TB, you realize that there are these strands, these reddish strands in the TB, indicating an acid-fast bacillus. Once we see this, it gives us the positive or best diagnose or definitely diagnose that the patient is having active TB. Okay. So please take note. Let's take note of this. Okay, let's take note of this. They will take the sputum 3 times on 3 different occasions, and then just slide on a microscope. We want to test for this reddish staining in the sputum. Once we see a reddish stain, it means that the patient is having what? Active TB, and we are seeing the acid-fast bacillus, okay, in the sputum. Are we there? All right. So this is what you should be observing on NCLEX when it comes to the sputum cultures, right? Good. So that is it. I see a question. Someone is saying that, Mr. Karim. So if the KFT, that is the quantifier on the T spot, is positive, doesn't mean the patient is, doesn't mean exposure. It's exposure, not really active. It's exposure. They are all being done to check exposures, okay? It's exposure. Penal testing, as I said, it is the sputum and the x-rays that really confirm that the patient is having active TB. And even within the two, sputum stands tall, okay? So please, let's get it right from here. All right. So these are the diagnostic investigations you should note for your NCLEX when it comes to TBs, okay? When it comes to TBs. All right. That's fine. Good. Hey, we are in class and people are chatting the master class speech. Please, let's pay attention. All right. Good. So now interventions, okay? Now intervention. All right. Now intervention. So what should you do as an RN when the patient is on your ward with TB? So collect sputum for cultures at least after 3 to 4 weeks, okay? Right. So once we start the treatment, okay? Once we start the treatment, after 3 weeks or 4 weeks, you should correct the sputum, okay? I said correct. Collect the sputum, okay? Doesn't mean we should get positive for all 3. Oh my God. Please, who will answer this question for me? Madam Patient's question. Do we need to get positive for all the 3 sputum or only 1? Yes. Oh. Any idea? Okay, I see here 4 persons. Madam Akama Bigel, yes.
At least 2. 2 should be positive.
Okay. All right. Madam Tina, yes, you too.
I was going to say all 3 should be positive.
Yeah, okay. Okay. So usually it should be all or at least 2. Okay. Usually it should be all or at least 2, right? For us to make the diagnostic patient. Okay. Okay. So usually all or 2. If we get 2 positive with 1 negative with a sound, it still makes us get the positive. Okay. It still makes us get the positive. Okay. All right. That is fine. Good. Good. All right. So perfect. We can move ahead, right? So after we start the treatment, we should monitor and see that the patient is negative or not, right? So after at least usually after 3 to 4 weeks, you have to take the sputum again and test if it still have the acid-fast bacillus in it. Okay, just take the samples and test if it still have the acid-fast bacillus in it. Okay, then consistently you keep on comparing. At least usually after every 4 weeks, you can do those testings. Okay, you just check the presence of the acid-fast bacillus in it. Now here, I have a question, an NCLEX question. Now, there is a way you collect the sputum to get an accurate result, right? So I think some of them came up earlier on. So one, when you are giving yes, if you do the first sputum and it's positive, please do the rest of the 3. In addition, we need the 3 of them to make a definite diagnosis, please. That is why I'm connecting the 3 sputums. Okay, yes. All right. So collect sputum for culture. So I have a question here. On the NCLEX, when it comes to sputum collections, one thing you should know is that never touch the inside of the sputum container or the container for the sputum. Never touch the inside. Once you touch inside, it becomes contaminated. It will give you a false result. Never touch the inside. Okay. 2, as someone just raised it up, you should collect the sputum early in the morning, please. Whether there are new development, we keep on improving in science. Okay, we keep on, because of the increase in technology, we keep on improving in science, right? So there will still be some development that you can take sputum cultures anytime, but please, for the sake of the NCLEX, and then what I have read, please, it should be done early in the morning. Early in the morning, okay? Chest X-ray. You do the chest X-ray in addition to the sputum, okay? Chest X-ray in addition to the sputum, yes. So we do it early in the morning. The reason is that we believe that once you wake up, there is more accumulated microorganisms in your mouth. Okay, so we can what? We can detect the acid fast bacillus in the sputum very well. Okay, so when we take it right early in the morning, usually at dawn, you can get an accurate result by that time. By that time, you've not spit, and you've not spit it out, you've not drink water, nothing has entered your mouth to interfere with the organisms there. You've not done anything like of that sort. So it gives us the accurate or the maximum organisms we can get in your mouth at that time. You just wake up. Okay. Even if you wake up, you see that your voice is a bit deep. Because your throat is now opening. Okay. Your throat is now opening. So more things are there. Okay. More things are in your throat. Okay. That is something you should know. Okay. And then organisms are also active at night. You get it. So at that time, we can get an accurate result. Okay. So please, for our NCLEX sake, let's just take note of that. The sputum is collected early in the morning. Okay. Where we can get enough microorganisms to detect the acid fast bacillus. Now, my question is this: when testing or when collecting sputum, one thing you should also know is that you must cough. Forcefully to bring the sputum out so that we can get enough of the microorganism. So you must really force it out. I get my point. You must really force it out. My question is, should you wash your mouth before the procedure? If yes, why? If no, why? Yes. Answer with rationale. If yes, why? If no, why? Okay, Madam Tina.
Please, you just said that we need more of the bacteria in order to make a definite diagnosis. And when you wake up in the morning, that's where you have most of the bacteria in the throat. So if you wash your mouth, I don't think it will affect the quality of the sputum. But if you gargle, that's when I can say that it will affect it. So washing your mouth, I think you can wash your mouth, but not with any what is it called? Not mouthwash, just normal water will do.
Okay, right.
That's my thinking.
All right, good. Madam Obapa, me. I see your hand up. Yes.
Bosaki, I think no, because even with the sample, we don't need just spitting out the sputum. We need the phlegm, the thick one from your chest, from the chest actually. So before even the procedure, you advise the patient that it should cough out so that you can get the one coming from the chest, not from the mouth.
Yeah.
So I'm thinking that if you wash out the mouth and maybe you couldn't get enough from the chest, it might interfere the bacteria that probably might already come out to the mouth.
Okay.
Yes, so I think no, and we should also advise patients how to take the sample as well. Thank you.
Okay. All right. Okay. Madam Esther, one last contribution, and I come with my answer. Yes.
So I think you can wash your mouth because so that we don't add the oral flora to the sample.
Okay.
Yeah.
Okay.
That's what I think.
Yes. All right. So please, this is the right answer. This is the right answer. Please take note. If you see on the NCLEX, wash your mouth prior to the procedure, it is wrong. Please, it is wrong. What you do is you rinse. The word they use on NCLEX is rinse. You can rinse your mouth before the procedure, but you can't wash your mouth before the procedure. So please, let's get it right away. If they ask you, a patient with tuberculosis is being admitted to your ward, which of the following statements made by the patient indicate correct understanding? I will wash my mouth before the procedure. Wrong. I will rinse my mouth before speaking. It is correct. Please, they rinse their mouth, but they don't wash. That is why people were saying you wash, but you don't wash it deeply. You don't. It is rinsing. The NCLEX term it as rinsing. Then they use rinsing for the right answer. So please, let's take, if you see wash and you think wash, they'll mark it wrong because it is when you wash, they believe that when you wash, washing can take away some of the microorganisms. So you can just do a rinsing. So there's a difference between washing and rinsing. When you wash a bowl before you rinse a bowl. So washing is a bit deep. You use soap to wash clean before you rinse. Rinsing is just using some small water, just to, you get it. So you can rinse your mouth towards the procedure, but you can't wash. Clear for your NCLEX. Okay. All right. Let's move on. So 2, high carbohydrate, high protein diet. Okay. High carbohydrate, high protein diet with small frequent meals. Of course, this patient will have dyspnea, difficulty in breathing. So do you know when they are about to eat, they find difficult to eat more at a time. They find it difficult to eat more at a time. Okay. Because of that, there is increase in oxygen demand. So they don't eat plenty, which can cause weight loss. Because of that, they must be fed in bits. Okay, they must be fed in bits, but then the bits should contain high carbohydrate, high protein. Okay, to maintain or increase their weight. Then 3, they need a directly observed therapy, or what we call the DOT. Why? Because in TB, the management is long, 6 to 12 months. The patient will take drugs 6 to 12 months. So at the point in time, they begin to feel tired and bored with the drug. So they should engage in what DOT. We all know what this means. A directly observed therapy. The RN must observe the patient on daily basis, placing the drug in their mouth. Okay, on daily basis, placing the drug in their mouth. Okay, so that is something you should know. That is what we call the direct observed therapy. Then 4, isolate the patient and restrict visitors. Of course, they must be in what an airborne and isolation precaution and what a negative pressure room. Okay, so you isolate them because once they cough, they talk, they sneeze, it will spread. So isolate them. They should be in their rooms. Okay, very good. And then let me just say something small about cohorting. I know sometimes cohorting is a bit, challenging. Okay, I'm just saying this. We're not discussing cohorting. I'm just saying it. You can pair 2 airborne conditions with the same bacteria together. Please, I'm making emphasis, or I'm repeating. You can pair 2 airborne conditions with the same bacteria. So you can pair 2 people with TB in the same room, but don't compare 2 different airborne bacteria. So you can't pair measles and TB in the same room. For your NCLEX sake, please take note. You can't compare TB and the measles. They are all airborne, different bacteria in the same room. But you can cohort, right? You can cohort 2 measles in the same room, 2 TBs in the same room, but don't pair different airborne organisms. Okay, like different conditions airborne in the same room. No, you shouldn't do that, right? So this is just by the way, right? Madam, is it cool? Yeah, you can speak.
Yes, sir. Please, I just wanted to ask, what if infection occurs? For example, if somebody has TB and is recovering, and you bring in another patient with TB, and now that patient is still in active state and then tends not to reinfect the other person who was recovering already.
Yeah, so that one, you should separate them. Okay, this one is a practice question. Okay, I'll keep that one as a practice question, and then Mr. Receive your question. Can you cohort latent TB with active? You are going to worsen the case. The patient has latent. The patient doesn't have active. Why should you cohort with someone who has active? No. Okay, no, right? And then if the patient is recovering, it means the patient is you should isolate the patient from those with the active TB. So prevent the condition from worsening or getting worse. Okay, right. So that is something you should know. And then mind you, Mr. Yusuf, when you have latent TB, as I said, and you don't take treatment, it will extend to active. So you don't have to pair a patient with latent to a patient with active TB. No, it's not done. Right. Good. All right. Then isolate patient and restrict visitors. Of course, you've said it already. Then test family and close contacts. Okay, you test families and close contacts. Yes, like the TB, the way they spread. If you are sleeping with your wife, your husband, your sisters, your brothers, they can all get it. So you must test them as well. Then you educate patient to cough or sneeze in a paper towel and flash. So if it's a paper towel, like let's say something like a tissue, I'm just an example, a tissue or something like that. Once they spit inside or cough or sneeze, they must flash right away. Okay, they must flash right away. Okay, and if it is an airtight bag, you seal it and then you discard it. Okay, so it's either a paper towel and then you flash, or an airtight bag, then you discard, right? Then last point, use non-hormonal contraception, especially when taking rifampin. We'll talk about the drugs very soon. We'll go into details about the TB drugs very soon as well. So let me hold on with this one. I mean the normal hormonal contraception, right? So let me hold on. Right. So the precautions, the airborne precautions. TB is airborne, so you need airborne precautions. The NCLEX, this is what you should know. You should keep the patient in a negative pressure room. What we mean by negative pressure room is that air can enter, but air does not leave. Okay, just know this. Just know this. Just know that air can enter a negative pressure room, but air cannot leave. Okay, to the surroundings. So please take note. And the doors must be closed. The doors must be closed. In droplets, you can open the door. By airborne, the doors must be closed. Okay. Then the RN must wear an N95 mask. The RN must wear N95 mask. The RN must wear N95 mask. Then the patient should be in surgical mask if transported outside the room. Forgive me. I'm having some throat issues, but it's not easy. So surgical masks for a patient if transported outside the room. For example, for X-rays, for laboratory investigations, or anything outside the room. But please take note, it shouldn't be often. The patient should not be transported outside the room often. It should be done only on request, probably for an X-ray for a lab. And then they should be in a surgical mask when leaving the room. Okay, so this is something you should know for your NCLEX when it comes to airborne and some management for the patient with TB. Okay, right. Now let's talk about the drugs. Right, the drugs. So in TB, please take note, TB2, when it comes to the drugs, NCLEX like it a lot. NCLEX like it a lot when it comes to the drugs. NCLEX like it a lot. Okay, so the pharmacology, a combination of drugs used to treat TB, typically for 6 to 12 months. So TB, if you are diagnosed with TB, it's not easy. Imagine a whole year. You are taking a drug for a whole year. Okay, it's not easy at all. It's not easy at all. Okay, Madam Regina, yes, you can speak.
Yes, sir, please, can you go again on the mask issue, the wearing of the mask?
Okay,
like if you are
RN must wear N95 masks. RNs wear N95. So just take note, RN N95. RN N95. Patient is surgical mask when transported outside the room. Okay, so usually the patient, they should be in surgical mask. The normal surgical masks that when COVID came, we're wearing here and there, the blue ones. Okay, they can wear those ones. Okay, but the RN, you should wear N95. N95, not a respirator mask, nothing. N95, it can filter the bacteria very, very, very well. So N95. But the one the patient is being transported outside the room, it should be what? It should be a surgical mask. Okay. All right. Good. So that is something you should know. Okay. Good. Are we there? What if the patient is in the room? Yes, if you're in the room, you can wear surgical mask. Same. Okay, it's the same thing. If there's a need, for the patient to wear surgical mask, you can just wear if there's a patient to wear the mask in the room, you can. And then sometimes they all have to be in mask because of the spread. Okay, so they still have to be in surgical masks in the room as well, right? Yes. Any question? I saw a hand up, but I think the hand went down again. Or the question is being answered. All right, that is fine. So let's study the drugs, ankles area as well for our ankles. Okay, then maybe we are good to go for tuberculosis. Okay, all right. I'm sure you are following. We are learning, and it's taking place for our ankles, right? All right, so let's move to the drugs. Remember the word peri. Remember the word peri. P-E-R-I. Anytime you hear TB, remember peri, 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 peri. Okay, P-E-R-I, P-E-R-I. Why the word peri? The word peri means cover, surround. Okay, this is just an let me say just mnemonic or something like that. Just remember, okay. Peri means surround. Okay, you can just Google on Google and see. Peri means surround, cover, encapsulate, engulf. Okay, peri. That is what the meaning of the word peri. So do you know in TB, in tuberculosis, if your immune system is strong, what does the immune system do? It encapsulates the bacteria from spreading. It engulfs it, it covers it, it corner it, so that the bacteria will not spread if your immune system is strong. So do you know the TB drugs are given to work in that manner? They are being given to cover, engulf, and encapsulate the bacteria from spreading. So that is the why we have the word peri. Okay, so remember the word peri. So P-E-R-I. So the first P is what? Parazinamide. Pyrazinamide. Okay, parazinamide. What does it do? It kills the bacteria. Now, what you should know for the ankles is this. What does this bacteria cause? It causes hepatotoxicity and increases uric acid levels. It causes hepatotoxicity and increase uric acid levels. So don't give this drug to a patient with liver cirrhosis. And then don't combine acetaminophen with this drug and give to a patient for TB. You are going to worsen the case. Are we there? Right on track. Don't give parazinamide to a patient with liver cirrhosis, and don't give it concurrently with the patient taking acetaminophen, because acetaminophen also causes hepatotoxicity. It can damage the liver as well. Are we there? So you meet this question on the ankles. A patient with TB is being prescribed parazinamide for the treatment of TB. Which of the following drugs should you clarify by the physician? Clarify acetaminophen or paracetamol, or any drug you think can cause hepatotoxicity. Okay, are we there? Right. Thank you, Madam Mary. Yes.
I'm saying that. So does it mean that as it increases uric acid level, can we also say that in gout it is contraindicated, since gout is about uric acid?
Yeah. So you down to have uric acid. Yes, of course. Okay, of course. You should monitor it very, very carefully. Okay. Yes. Madam Sarah. Yes.
Yeah, so I think I read a question somewhere. Is it the one that causes the complication? They causes
I can't hear you. I can't hear your network. I can't hear you. You're breaking. Oh
in
God.
the feet or the stream.
Please repeat.
You said
You will get there. You will get there.
hello,
We're talking
hello.
about. Yes, I'm hearing. I'm hearing. Yes.
Yes, but
You
can I
are
ask?
breaking.
So, the patients with the parazinamide, if they have
Eh,
temperature, what will we use to treat the temperature?
if they have temperature.
Because usually we give them para.
Yes, for temperature, but there are a lot of drugs we use to treat temperature. Or why is the only
But
drug?
para is the common one. The common
So you
one
look,
that
look for
we
the
are aware
alternative.
of.
Okay, you can leave the alternative. Alternative drug can use for what do you call it, paracetamol, right?
Okay. Yeah.
Yes, you can. Okay, you can. Right. Someone is being saying, I think I know the same as paracetamol, or am I lying? It's not the same as
Yes, it's the same as para.
it's the same. Okay, so we leave for the alternative. Okay. There are a lot of drugs that can, help reduce fever. Even NSAID sometimes can help. Okay, reduce fever. All right. So that is it. Okay, Papa May. Yes, you can speak.
Bosaki, I understand my sister who just spoke. Like,
Mm.
meaning we have killed our patients because we always give para with the TB drugs for they usually have high temperatures. So we give with paracetamol and that is what we usually do. So meaning we have killed
You are killing them,
many.
you are killing them, pa. You are killing them, pa. Plenty. Okay. All right. So you look for some alternatives, okay, so that you prevent the liver damage. Okay, the liver damage. You know, this is why you should educate our parents. You know, our parents like para a lot. Small headache, para, anything para. You are damaging your liver, please. It is hepatotoxic. Okay, the more you consume it, the more you damage your liver. Okay. All right. That is it. Okay. Good. So you look out for that. And then another thing you should look out for, it increases uric acid level. Okay. It increases uric acid level. Okay. So because of that, you should be checking the patient's kidney very, very well. Okay. You should be checking the patient very, very, very well. Okay. You should be checking the patient very, very, very well. The kidneys, you check your BUN, your creatinine levels, because it can cause what? Kidney problems when there is more uric acid. If a patient starts taking paracetamol and reports BUN above 20, no, normal BUN, right? 10 to 20. Normal creatinine level 0.6 to 1.3 milligram per deciliter, right? So once it goes up beyond these values, know that the drug is causing what? Serious effects, right? And you should start holding the drug. Okay, you should start holding the drug. So please be mindful. And then my madam just said in gout too, you know, in gout you have increased uric acid. So if you can combine it, you worsen the case. And then one other thing you should know is that you can administer with food to prevent GI abscess. So that is that for paracetamide. Ethambutol. Ethambutol, what should you know? It prevents the bacteria from reproducing. Okay, usually these ones that is not really important. The side effect is usually common in the ankles. Okay, so what does it do with ethambutol? It causes optic neuritis. It causes inflammation of the optic nerve. Anytime you give ethambutol, it causes inflammation of the optic nerve. So it causes optic neuritis. Due to this, they must engage in regular eye checks to prevent any damage to the patient's eye. And there's decreased visual acuity when you're taking ethambutol. So if the patient reports some of these signs, you should know that the drug is causing them. Okay. So you observe ethambutol, observe for what? Optic neuritis, and then you do regular eye checks to prevent what? To prevent the patient's eye from being damaged. Madam Doris, yes. You can speak. Oh. Okay, I think he's not speaking. Right. So that is that for paracetamide and the ethambutol. Don't forget Perry, right? So let's move to R. So R, we have rifampin. Okay, rifampin. So the rifampin kills bacteria. And then the side effect for ankles, what should we expect for ankles? It causes reddish orange discoloration of body fluids. It causes reddish orange discoloration of body fluids. Okay, it causes what? Reddish orange. So this patient will have reddish orange urine, saliva reddish orange, sweat reddish orange, tears reddish orange. Okay. Oh, the gout. You know, in gout, if a patient have gout, there's increased uric acid. Am I lying? There's increased uric acid. And then this drug, the paracetamide, can also increase the uric acid level. So if you take some of this drug in gout, you will treat and treat and treat. It's not working. I get to my point. That is what I just wanted to say. All right. Okay. Okay. Good. Boss, where can I get the lecture notes? Please, you can get the lecture notes on the once you are listening to this class. Okay. And then subsequently on our YouTube channel or on the dashboard. And by please, what I will say is that please adopt this strategy when you're preparing for NCLEX. Try and know things once and for all. Okay, please. I know we all forget sometimes. Trust me, we are all humans. We all forget sometimes. You will learn and forget. But please, there are some things. I'll just encourage all of us. Let's try and learn things once and for all. Then don't let's be going back. It will delay your time. NCLEX is a lot too. Okay. So whilst you are in class, pay attention and listen to one for all. Don't be like, oh, they'll be recording. Oh, it's going to be posted. I can have access to it. Okay. So please, is it Idrisu or Madam Idrisu? Please, the recordings, the lecture notes, we don't share the slides. No, for the slide, we don't share. Okay. So you are just going to have access to it whilst you listen to the recording later on. Okay. All right. Or whilst you're in class. Okay. All right. So that is it. Good. So rifampin, what does it do? It causes reddish orange discoloration. Your tears, your urine, your body fluids, everything becomes reddish orange, and it's normal. So because of this, your tears, when you are crying, the tears that can also become reddish orange. So do you know, because of this, do not wear contact lenses. It will stain the contact. So wear non-contact lens rather. Okay. Don't wear contact lenses. Wear non-contact lenses or soft ones that will not stain with the color, the discoloration. Okay. So that is something. And then it decreases the effect of hormonal birth control. Rifampin. When you take rifampin with Lydia contraceptive, with Postino 2, you are wasting your time. Rifampin decreases the effect of oral contraceptives on the body. So if you want to prevent pregnancy, don't use the hormonal birth control, the Lydias and the rest. No, switch to IUDs and then the rest. Are you getting my point? So please take note. Rifampin decreases the effect of what? Hormonal birth control, the hormonal ones. So you can switch to non-hormonal, the IUDs and then the rest. The examples of the non-hormonal ones we know. Okay, but for the oral one, the Lydia and the rest, it will decrease the effect of it. And then you may think you're preventing pregnancy. It will not work. By the time you realize you are pregnant. So please don't take rifampin with oral contraceptives or the hormonal ones. Always use the non-hormonal contraceptives. Are you getting my point? They can ask you this on the NCLEX as well. So that is something you should know for rifampin. Reddish orange discoloration, don't wear contact lenses, and decreases hormonal birth control. Then lastly, isoniazid. It does what? It kills bacteria. Now, what should you also know for your NCLEX? It causes hepatotoxicity. So avoid hepatotoxic agents like paracetamol. Once again, we are here. So two TB drugs causes hepatotoxicity. Which one? Isoniazid and paracetamide. Okay. So don't take acetaminophen with isoniazid also. 2, what does isoniazid cause? It causes peripheral neuropathy. It can begin to have issues. It can damage your nerves. At a point in time, you walk and not feel. You will step on a nail, and you not feel like you step on a nail. Okay. So to prevent this peripheral neuropathy, take isoniazid with paradoxin or vitamin B6. Take isoniazid with pyridoxine or vitamin B6 to prevent peripheral neuropathy. Now, on your NCLEX, you had a case study on TB, right? You started giving isoniazid, but you didn't give the pyridoxine, and now patients have peripheral neuropathy. What should you do? Please take note. You are going to care. Most of the time, they ask this question, care of the foot. Please, you use the same thing you know for diabetic foot for this same patient. Okay, so what should you do? They shouldn't walk barefooted when there's peripheral neuropathy, because when the nerves are destroyed, when they step on something sharp, they will not even feel. So what should you do? They should walk barefooted. That is 1. 2, what again? They should always do what? Test the temperatures of water before they use it. Okay, to prevent burns. Right? Consistently, they should wash their leg and use lotions to prevent cracks and other stuff on their legs. Okay, so these are some of the things you should know once the patient ran into peripheral neuropathy. Okay, once the patient ran into peripheral neuropathy, you should start doing these things to prevent foot ulcers and then the rest. Okay, then lastly, avoid aluminum containing antacids within 1 hour after taking the drug. When you take isoniazid, don't take antacid within 1 hour. It should be after 1 hour, because it will cause drug-to-drug interactions. Okay, right. So isoniazid, don't take paracetamol. It causes hepatotoxicity, right? Peripheral neuropathy. So take what? Pyridoxine or vitamin B6 and avoid antacids. Please, any question on the drugs? Any question on the drugs? So you should know this for the NCLEX, okay? Very, very key. Okay. All right. So and it, Madam Taku, yes, you can speak.
Thank you, boss. Please, I wish to find out how long should a patient take the medication before becoming in a like, let me rephrase. I want to find out how long a patient should take their medication before becoming non-transmissible.
You want to find out when you should take the drug.
How
You want
long
to
a
find
patient
how long before you don't become infective, right?
before they cannot transmit it to another person.
Okay. So this one, you must adhere to the treatment regimen. You know, the drugs will be taken like 6 months, sometimes 6 months, sometimes 7 months. Okay. So you must be on the drug, and then usually after these months we can now assess. But mind you, okay, sometimes all right. Sometimes, as I said, once you keep on taking the medication, after every 4 weeks, you must take the sputum and test if the acid fast bacillus is still there after every 4 weeks. Okay, but even if you test and it's negative, please you have to adhere to the treatment regimen. Okay, for that given period, then you can say that you are okay. Okay, all right, Madam, is it Hamdia?
Yes, I'm there. Yes.
Yes.
Good evening. Please,
Yes.
I would like to know if once the client is diagnosed with PTB, the person has to take all the 4 medications that you listed here, or the person can take any one of it.
And so it is okay. This one too depends on the doctor's prescription, but it's a combination. Most of the time, they can combine isoniazid with rifampin or paracetamide, and then it's not necessarily going to take all 4. No, okay, they can combine 2 or 3 of them and give to you. Are you getting the point?
Okay. And secondly, you talked about spinal TB in the beginning of the PTB. In the beginning. So the spinal one too, is it the same treatments that we do for
Yes,
it?
but the same bacteria, it's the same mycobacterium tuberculosis, so the same treatment. Okay.
Okay.
Yes.
But it's like the person doesn't present the symptoms that the pulmonary tuberculosis presents.
Okay, so most at times, before a patient will have spine TB, it begins with pulmonary, the lungs, before it will extend. Okay, before it will extend to the spine. So most of the time, those symptoms with the lungs and those things might be present. Okay, might be present, right? In addition to other things like back pain and then the rest. Okay, all right. Is it Idrisu? Your hand is up. Please you can speak, madam. Is it Idrisu?
Idris Shafi. Yes, sir. Please, the question the lady was asking about when somebody start the TB treatment, at which point that the person cannot be infectious to other people. I don't know, maybe whether you didn't understand the question well. I think it's 2 weeks that if the person start the treatment at the active phase, when he took the treatment for 2 weeks, the organisms become confined and they become dormant in a way that they are at that point the person is no more infectious.
Okay. But okay, so that's fine. But you don't stop the treatments, right? You still continue to the
continue the treatment. At that point, he can mingle with other people.
Okay.
He's not.
I was thinking that direction more. Okay. Yes, I was thinking that direction more. So as has been said, 2 to 3. I see Madam Leslie commenting the chat box 2 to 3 weeks as well. Madam Esther 2 weeks of active treatment. Okay, so within several weeks, 2 months, the patient can now socialize, as you said. But then please, the treatment continues. Okay, it continues with the doctor's prescription before you can say that. I mean, you are now okay. Are you getting my point? It continues till they say you are now okay. Okay, all right, that's fine, Madam Mary. Yes.
Okay, thank you very much. As the other lady was asking about the extrapulmonary TB, that one, the client may not be producing sputum, although he was having the sign. That's why you have to use other diagnostic tests to diagnose the client. So some of the doctors, when they see the signs of something, they based on what X-ray, even if a sputum is negative, to diagnose the other part of the TB.
Right.
Thank you.
Thank you so much. Yeah, Mr. Karim. Yeah, Mr. Karim. You can speak.
Okay, so I want to clarify something. So we are saying that if somebody has active TB and commences treatment, so 2 to 3 weeks, it means that the person can socialize.
Yeah.
But what would be the indication? Will it be that the person will do maybe gene expert for a number of times to confirm that, okay, this number of times he has been negative before you can say that the person is no more infectious? Thank you.
Yeah, I think, yeah, I've been saying this, like, when you start a treatment, within the next 3 weeks, 4 weeks, you should start taking the samples. Okay, at that point, there could be that you can start recording negatives. Okay, please take note, right? At that point, you can start recording some negative sputums. Okay, so within that time, you can start taking a sputum the sputum smear microscopy to check if there's still presence of the bacteria in there, right? So within that time frame, we can use that one to help. So once we start to get negatives, it means that now we are confining the bacteria and the patient can now socialize. All right. Yeah, that is it. Okay, good. So that is that for the drugs. Okay, so that is that for the TB drugs, and I'm sure we are following well. So these are things you should just know for the NCLEX. Please take notes. Okay, all right. Please take notes. Ethambutol causes what? Optic neuritis. It destroys the optic nerve, and then you must do regular eye checks. Okay, you must do regular eye checks. That is that for ethambutol, right? So just remember Perry. P for paracetamide, E for ethambutol, R for rifampicin, and then I for isoniazid. We are good to go, right? So now the complications of TB, drug resistance. So TB bacteria can develop drug resistance to the antibiotic because you are taking it for long. Okay, you are taking it for long, so there can be some complications whereby you develop drug resistance to the drug. Then treatment failure. Treatment may not be effective, especially if not completed, especially not as prescribed. You are taking a drug for 6 to 12 months. 6 to 12 months. Okay, just imagine. Sometimes you can even forget that you are even taking some drug. Okay, so that lapses will not give us an accurate treatment and can lead to treatment failure. Then lastly, transmission. Untreated TB can spread to others and to the entire body. So this brings us to the end of tuberculosis. If you have any questions, you can ask. Yes, any question you can ask. I'm sure you've paid attention. We are following the class very well. You're enjoying the class too, right? Slide on rifampicin. Okay, this is a slide on rifampicin, please. All right. Any question? Any question? I think we are good. We are good for tuberculosis, right? Any question we meet on tuberculosis, we will be able to get it right away. Good. Please, are we here? Are we here? Okay, Mr. Karim. Yeah, I can see your hand. Yes.
Yes, more. So earlier I saw a question on the chat box. Someone asked about which of the drugs should theramine containing foods be contraindicated. I actually wanted to ask that. Thank you.
Oh, okay. All right. Okay, I'll come back to that. Yes, someone has a question in the chat box. So will you subsequently test? So will the subsequent test be done for 4 weekly till? Yes, every 4 weeks. Okay, like you do it till you are done. Okay, yes. Madam Nana, how are you? Okay, your hand is down now. Right. Okay. All right. So you're asking which of the TB drugs should you avoid thiamine, right? That's the question.
Yes, please. Yes.
Okay. So usually you don't take thiamine with isoniazid. Isoniazid, okay. It's isoniazid. Okay. You don't take thiamine with isoniazid. Okay. All right. Okay. Are you there? So you don't take it with isoniazid. Okay. And then not isoniazid alone. You know, please take note of this. Examples of monoamine oxidase inhibitors. Examples. This can be your assignment, please. It can be your assignment. When you are free or when you are done, research on examples of monoamine oxidase inhibitors. Don't take monoamine oxidase inhibitors with thiamine foods or foods containing thiamine. And then please take the NCLEX will not bring thiamine. They will bring examples of food contain or examples of food that has thiamine inside. So you must be able to identify those kinds of food and avoid them when taking isoniazid and monoamine oxidase. In fact, do you know isoniazid is a mild monoamine? Okay, it's a mild monoamine inhibitor. So please take note. It's a mild monoamine inhibitor. So please do well to research on examples of monoamine and examples of food containing thiamine. It's okay, so that you don't combine them on the NCLEX if you see them, right? Good, that's fine. Someone said you want to see complications, slide for complications is here. Okay, all right, good. So are we okay? I think we are okay, right? With no question. We can proceed to some questions on my slide now, right? Good. All right. Who will read for us? Who will be our reader today? Whilst we do some questions and close. Who will read for us? Who is gonna read? Madam Regina. Okay, Madam Regina. Madam Regina, you can read. Oh, you can't open. Or should I read myself? Nobody is there to read. Okay.
Hello.
Yes.
Hello.
Yes.
Okay. I'm reading.
Okay.
The right forearm of a client who has a purified protein derivative, PPD, test for tuberculosis is reddened and raised about 3 millimeters where the test was given. This PPD could be read as having which of the following results? A, intermediate. B, needs to be redone. C, negative. D, positive. It's negative.
Yeah, it's negative, right? Why? Why negative? Why?
Because we know that the normal range is between 5 to 15.
Are you sure that's the reason for the answer?
No, for the various, like the duration. The duration should measure between 5 to 15.
Okay.
For the various categories of people, the immunosuppressed, health workers, healthy people, but this one is below the 5.
Okay. Okay. Okay, all right. So that is it. Okay. Okay. Madam Mary. Yes, Madam Mary.
Okay. Well, just like she said, the duration is 5 to 15. So even with the immunocompromise, it should be 5, at least 5. So now that is 3, meaning that it's negative.
Okay.
Thank you.
The answer is C, right? So this test would be classed as negative. A 5 millimeters raised area will be positive if the client has HIV or had recent close contact with someone diagnosed with TB. Intermediate is the term used to describe. Please, let's mute up. Describe results of a PPD. If the PPD is reddened and raised temperature is considered positive for according to the study. Okay. Please, let's mute up. Please, let's mute up. Please, let's mute. Madam Sarah, yes, you can speak.
I said, in your slide, you said that things shouldn't be red. So why are you now choosing red?
No, it shouldn't be red. It shouldn't. You need induration, and induration will be a raised thing. I saw the picture of the swelling. So once you see red, reddened and raised about 3 millimeters.
So that one there is it's in duration.
They didn't say redden only. Okay. Let me, because of what you said, to prevent any mistakes, just take note that usually after they inject the solution or the purified protein derivative, you see 2 things: redness and then duration. I think I have to make this emphasis. You see 2 things. The one that you should focus on to diagnose is the duration, not the redness. That is why I stated duration, not redness. So it simply means that you may see redness, but that redness should not be your basis for diagnosis. It should be the raised substance with the raised fluid over there. Okay.
But the statement looks as if when it's red, it means we cannot use it. So I mean, I was choosing the B answer that it needs to be redone.
No, if it is red, it does not. It doesn't count. It should only be on induration. Reddish does not count. Okay. Are you confused?
So it shouldn't be red alone, because the note says induration and not red. So it means that when we see red, and then we shouldn't look for it. But
it's wrong. It's
now
negative.
it means that it should be raised and red.
Okay, Madam Sarah, the thing is that when you are diagnosing a patient with skin mantle test, your focus should really be on the duration. If you see redness alone, don't pay attention. Don't really focus on it. Like if you see redness alone, okay, let me say this. If you see redness alone without induration, it's negative. It means that there was no bleb. It's negative. So to make it easier, and then there will no confusion, we are going to use 2 things: redness and induration. But to diagnose the patient, we are focusing on duration, not the redness. Redness does not give any clue. It's just redness, and it's negative. We should rather see the duration to diagnose the patient. I'm sure you are okay now.
So it means when we inject, we will see redness there.
Yes,
but when we want the results, there should be an induration, because whether there is a negative or positive, there will be redness at the site.
Yes,
but the induration should give us the result.
Exactly.
Yeah, thank you.
You're welcome. Exactly. Thank you for understanding. Okay, because it's important. All right. So that is that for this question. The answer is C. Yes. Next question, Madam Regina, please read.
Okay. A client has active TB. Which of the following symptoms will be exhibit? Will he exhibit? A, chest and lower back pain. B, chills, fever, night sweats, and hemoptysis. C, fever of more than 104 Fahrenheit and nausea. D, headache and photophobia.
Okay. Right. So the answer is what? We are all picking B. I'm sure we all know how to calculate from Fahrenheit to degrees Celsius, right? Do we know? I'm sure most of us know by now, if not almost. So this one, you subtract. Okay, when Mary want to say it, let me allow when Mary to say it. When Mary, yes. How do you? So let's use the 0.0
minus 32. Or when you get the answer, all divided 1.8.
Exactly. Okay. So let's all pick our phones. Let's all pick our phones to do some calculation, right? So 104 minus 32. Okay, 104 minus 32. We are getting 72. Then you divide 72 by 1.8. So this temperature will be what? Will be 40. Okay, 40 degrees. Are you getting my point? So that is how we calculate from Fahrenheit to degrees Celsius. Okay, right, good. So we also know that the patient will have a low grade fever, not a high fever. So 40 will be too much. Are you getting the point? So the answer is B. The typical signs and symptoms are chills, fever, night sweat, and hemoptysis. Chest pain will be present, okay, from coughing, but it isn't usual. Clients with TB typically have low grades, not higher than 102. Okay, nausea, headache, photophobia aren't usual with TB symptoms. Okay, next question. Yes, can you read?
Okay. Which of the
can you hold on and ask the question?
Which of the following
So most of these patients that we treat, so does it mean that the temperatures are from another place, and so we have to use another antibiotic to treat it?
It could be that the high temperature.
All of them have high temperature, very high.
It could be that the temperature, and let me say this. Sometimes, when it comes to diseases, most will present with something else. I mean, one individual out of thousands will present with different things. Please mind you, high fever can sometimes be consistent with TB, but it is rare. Okay. Most of them present with low fever. Okay. Most of them present with low fever. So let's take note. Sometimes it can be, but it is rare. Okay. So you usually use the what do you call it? The low fever rather. And then you should be looking out for, if it is spiking temperature here and there, you should be looking out for the causative reason. Okay. I mean, there's something causing the high temperature often. Okay, but sometimes TB patients do have high temperatures. Okay, it can happen. Okay, all right. It's not common in plenty of them. Yeah. So which of the following diagnostic tests is definite for TB? I see people TB.
I didn't finish reading, but they have chosen.
But why did you pick B? Why? I made mention of this several times. So I'm lying. So the answer is C, sputum. Right? It's sputum. So the sputum culture for mycobacterium is the only method for confirming the diagnosis. Okay, use them with definite. Lesions in the lungs may not be big enough to be seen on X-ray. Skin test. Hey, are we reading the right question? Yes. So it's C. Okay, sputum. Right. Next question. Yes. Next question.
A client with a positive Mantoux test result will be sent for a chest X-ray. For which of the following reasons is this done?
Yes. This question, please relax before you get it wrong. Sorry. A patient with positive Mantoux test, meaning that there's exposure. And then I said, you don't depend on the Mantoux test. You don't depend on exposure alone. You need sputum and X-rays to confirm. And now the patient is being sent for a chest X-ray. For which of the following reasons is this done? Yes. To confirm, to determine if a repeat skin test is needed, to determine the extent of the lesions, and D, to determine if this is a primary or secondary infection. Those speaking A, we just read the rationale. Just read this rationale. Sputum culture for mycobacterium is the only for confirming diagnosis. Now, so let me go back to my C. What if the answer is A? What if the answer is A? So this question, I think the rationale is somewhere else. Okay, the rationale is we will go there very soon. But let's do this question. I think when I was doing the slide, I made a mistake. I interchanged the slides, right? Forgive me for that. But the rationale is still there. So let's do this one. Yes, let's do this one before we go to that question.
Okay.
Let's do this.
A client with a positive skin test for TB isn't showing any signs of active disease. To help prevent the development of active TB, the client should be treated with isoniazid 300 mg daily. For how long?
Yes, this one there, you should pick it easily. You should pick it easily. You should pick it easily. I see. I'm seeing odd numbers. A, B, C, D, A, B, C, D, C, D, A, B, A, B, C, B, B, 2 to 4 weeks. B, D, B. Okay, the answer is D, because of the increased incidence of the resistant strains of TB, the disease must be treated for up to 24 months. Okay, 24 months in some cases, but treatment typically lasts for 9 to 12 months. It is on my slide. Okay, I think it is on my slide. If we saw it very, very well. Okay, if you have a latent TB, you should undergo treatment. And usually TB management is a bit longer. Okay, it's a bit longer. So it's 9 to 12 months, right? Isoniazid is the most common medication used for TB, but other antibiotics are added to the regimen to obtain the best results. Okay, so let's just know the time frame for the TB treatment. And I know some people pick the 10 to 14 days, the 2 weeks, because we said that 2 weeks you cannot mingle. That is why I think that is the question that question I was asked. My focus was more on the 6 month package. Okay. Like the 6 to 12 month package, right? In as much as after the 2 weeks you can mingle and those stuff, you should take the isoniazid for that requested period. Okay, to prevent it from becoming an active TB. Are you getting my point? Yes. Yeah, Madam Sarah, you can talk.
Yes, but I think the revamping, I didn't even see that. But I think they said they also give them revamping or something. But that one is the 2 weeks. They can take the 2 weeks.
The revamping for just 2 weeks. Oh, okay, I see. Okay. All right. So this question, a patient with positive Mantoux test will be sent for chest X-ray. But which of the following is the reason why you're doing the chest X-ray? Now the answer is this. The answer is C. Okay, let's go back. The answer is C, not A. The answer is C. I showed you this right now. The only way we confirm properly is the sputum, please. Okay, so the answer is C. So we do the X-ray. So if lesions are large enough, the X-ray will show the presence in the lungs. Sputum cultures confirms the diagnosis. I repeat again, sputum culture stands tall to be the best way to diagnose TB. There can be false positive and false negative skin test results. A chest X-ray can't determine if this is a primary or secondary infection. Okay, so the answer is C. So you are doing the X-ray not necessarily to confirm, but to see the extent of the lesions in the lungs. Okay, that is the reason why. All right, so this brings us to the end